At the lab last week, we got bumped from the lab because of semester one. It wasn't because I didn't want to be there with you guys and get you guys all up to speed on things. And Mary said nobody was disappointed, but I was disappointed because I was ready to go, but oh well. This Friday, we aren't getting bumped because cottage comes, so half of the class will be doing the cottage one course. You'll be doing the point of care class, and the other half will be doing all the other things that we have to do, and then we'll swap out. And once, as soon as the cottage one course is done and your badges have been uploaded, then all the rest of the stuff we'll do until we finish, and we finish at 3:00. So there's a lot to do. There's a lot of, it's just refresher, it's review, but there were other questions. That's for lab. Don't forget your badge. Everybody needs a badge. If you live far away and you don't have your badge, you have to go back and get it. So don't do that. Put your badge in your school bag or whatever you have to do, in your car, wherever you have to put your badge. Make sure you have your badge. That's no exceptions, because they don't want to come back and have to try to upload it on your badge later or whatever. So that's for lab clinical. We want to make sure everybody brings their badge. Everybody gets there on time. And I want to say it says 9:00. Is that correct on the planner? I don't want to pull it up yet. So please be there at 5 minutes till, because what ends up happening is they can't get started. We can't get started when people show up 10 minutes late and say, oh, there was traffic, there was this, there was that. Heard it all. Don't want any of that. So just be there on time for the lab on Friday. And of course, if there's an accident or if something happens on the freeway, there's not much we can do about that, right? We'll figure it out, but I don't want it to start off like that. For clinical, there was a bunch of questions for students, had a lot of questions about clinical coming from semester 2 to 3, being that, first of all, they said that the semester 3 students were just exceptional with the semester 1 students. That you guys were super helpful, you were super kind, you were very considerate of them not knowing, and even the ones that acted up and, you know, tried to act like they didn't care what was going on there. They had nothing but good things to say about semester 3 students. So that's a plus, that's a feather in our cap. As far as the paperwork is concerned, there were some questions, not about their paperwork and that whole shadowing thing, but about like care plans, concept maps, the old style care plans. In semester 3, you are allowed to use a concept map, but you are not required to use a concept map. If you want to use the care plans that you've been using, you can do that. Some people are very visual. They like the picture. They like the concept map. I personally don't work well with the concept map. I'm better with the linear. I like to write everything down that I'm going to be doing. But in semester 3 and 4, you have the option. So it is not a requirement. You don't have to do it if you don't want to. And I'm not sure if anybody can bring I can bring concept maps to lab on Friday so you can look and see, you know, the difference between them. And I'm not sure, somebody couldn't find one or make it work for them or something. I don't know, but we'll figure that one out. But it definitely is not required. It is just an option. As far as the advanced skills, I can't be any more clear. I said, we're going to get a refresher and then you can do that in clinical. Some clinical instructors were calling Mary and I and asking, can they do this? Can they do that? And I was just like, come on, they already know. I've already told them. And yes, they were supposed to be able to do it, but they got their lab canceled. It's not their fault. So that was one thing. The other thing is, I'm going to be very frank with you on this one, med errors. If you are a student in this program and you don't understand what a med discussion is, you need to step back. You need to know why you're giving a medication. There's zero tolerance now for med errors. If you make a med error, you're going to get dismissed from the program. There is now a zero tolerance because of everything that's been put in place. So there's not going to be leeway. There's not going to be, oh, we're sorry that happened. It's just going to be a dismissal. And if you get dismissed from clinical, you can't come back to this program. And you guys have worked way too hard to get into this program. So don't let that happen. You have to know why you're giving a medication. There's no question about that. I don't care what it is. I don't care if it's a Senecot. and the patient's plugged up, constipated, you have to know what that medication is and why you're giving it to the patient. Because you could have gotten in report, you see on their MAR, they get 9 o'clock Senecot, and you got in report the patient has been up with diarrhea all night. If you can't put those two dots together, then there's a problem. You're going to say, I'm giving this for constipation, but my patient has diarrhea. This is very like remedial, that example. But there's also the fact that there's pain medication that was just given and you're going to try to give it again. That's an error. There's, let me think of something. A parameter medication where you just walked right in, you just did the MAR, you didn't check a blood pressure. You gave a medication to somebody who, an antihypertensive medication to somebody who has a very low blood pressure. That is a med error. And a med error in this program is now zero tolerance. There's going to be no, remediation for that. There's going to be no discussion of that. And talking to the faculty and Mary over the weekend, it's going to be, that's like where the buck stops. We're not going to have any medication errors in this program for the mere fact that you have time to look at them, you have time to research them, and you have med discussion with your clinical instructor. So does anybody have any questions on that? There's two more things we gotta. So, okay, remember that you're giving something to another human being and it's your responsibility. So your responsibility and due diligence is to make sure you know why you're giving it and what it is. If it's a Skittles, if it's a candy, I don't care what it is. If you're giving something to a patient in clinical, you need to know what it is. So none of my students are going out that way. We're all going to be perfect in clinical. Not always perfect, but for meds, you're going to be perfect. Let's see. Okay. Your insulin pretest. You guys, that isn't something that I go over each thing with you. It is a worksheet. You work independently on that. It's solely for you to get your critical thinking skills up, to get your research skills up, where you're going to find this, do all that. I don't need to discuss that with you 50,000 times. You guys are on your own with that. And all you have to do is get it completed before Friday. Okay. End of discussion on that. Whatever you find is your research. Okay. You guys did, so many of them are so good. And it isn't a perfect exam, but it makes you get out there and work. It makes you get out there and think. What's up, Bear?
I just wanted to check, like you said, we're on our own, we're doing our research and whatnot. So like, as long as we have like the sources that we cite for
Absolutely
information on it.
And you know what, all it's going to do is help you with that first quiz. There's a few questions. I can tell you right now, we're going to go over giving insulin. We're going to do that in lab. Your first quiz might say, what are the steps that a student from SBCC does in a delivery of insulin for a patient? So step by step, you're going to be able to spell out exactly what you do. Are you going to find that written down somewhere? You're not, because I'm going to tell it to you. And if you listen and you go through the steps, you'll know how to do it. You're going to know how to do that also with the point of care teachers that are coming on Friday. I think there's 2 of them, really nice folks. We'll give them an SNA t-shirt for thank them for coming. But they get us up to where we can do blood glucose with your instructor in clinical. So that's kind of a fun thing. It's kind of nice to get to that point where we can do more stuff. And you can do that. And then the following week, you'll be able to do your insulin, because we'll go over all the steps. Everybody will get signed off and you'll be ready to go. Once again, we don't have that many things in this semester to get signed off on. I mean, today when we do cardiovascular, you'll see that the central line dressing change is thrown in there. We have insulin, we have central line dressing change, blood, TPN, that kind of stuff. Today we'll get through some of that, but we don't have that many things. So you guys are going to get really good at it. It's just muscle memory. You're going to get really good at all the skills that you have that are required of semester 3, because I know that semester 2 had a lot of skills. Now, one last thing before we get started. If you are struggling, it's week 3. It's only week 3. Today is the first day of week 3. How fast did that go? By next week, we're a month in. If you're struggling in clinical, if you're struggling with anything, you need to come forward right away, because we do have plans for those kind of struggles. Let's just say a student that came into the program late and doesn't understand how things work and is not feeling like their foundation is solid, and we have plans for that. We don't have plans for somebody that says, I'm not going to try to do any of that. I'm just going to power through and mess up and not do okay. We're not here so that you aren't successful. We want you to be successful. So if you have that thought, you know what, I'm completely overwhelmed in clinical, I'm not exactly sure, there are different strategies that we can help you with that will make you successful in this program. If it means going back a little bit, going backwards and starting over, so what? A semester or 2 is not a big deal in the big picture. You're going to be a nurse for a long time if you finish this program. If you are unsuccessful in clinical and you get written up and then you get put on probation and then you get kicked out of clinical, you can't come back to this program. That's just across the board. If you mess up in class and you're not getting the grades, but you're doing fine in clinical, you have the chance to repeat once. That's another thing. Nobody wants to repeat, but you can move out of something and get to something that feels much more comfortable, much safer, and be successful. Don't forget, people have this weird idea that, oh no, they're out to get me. They want to kick me out. They don't want me here. That's not true. If you aren't successful, we aren't successful. We want you to be successful. I mean, like, for instance, those weeklies. I looked at them early on in the week and there was just silly little errors that needed to be fixed. They got fixed right away. But if you do your turn in Sunday night late and today there's nothing there or it's wrong, you don't have time to correct it because we can't go back. So this week, almost everybody got their stuff and there's a few that missed. And I know it's only 1.25 points, but those add up. So if you think about it, in maternal newborn peds, it's 2.5 points. That's a lot of points to give up, especially for free. So doing those weeklies, the sooner the better, is really good, because if you don't turn in the right one, or you turn it in upside down, or I can't read the bottom line. There was one person where I couldn't read the bottom and it looked kind of weird. So that I just said, please make sure I can see the subject matter on the bottom line. It was cut off. There was only 1 out of 40 students. So I have to say, you guys did an exceptional job. Some people switched maternal newborn to peds. So when they see a 0 up there, they freak out and right away email me, what happened? What? No, you just switched it to the wrong place. If it's in the wrong place, you can't get the credit for it. So there's those little things, but overall, first week, perfect. And now we go forward and you just do it every week. The sooner the better, because if there's something wrong with it, you have time to correct it. Does anybody have any questions for me before we start cardiovascular, my favorite unit?
Linda, I do have a question. There's a few of us that have clinical scheduled on Friday, but also there's required lab.
Right. Don't worry. We will make it up. The extra labs on the end are going to be like, if you're done with everything, you don't have to come. I hope that makes sense. If you haven't finished, or because that's not your fault. So we added extra labs to the calendar. So most of you are thinking, well, shit, we got lab forever. We have it all. Well, you don't. As soon as you're done and you're steady on what you have to do in clinical, you're done with lab. Like I said, we have blood glucose, insulin administration with the vial and the pen. We have TPN and blood administration. We have central line dressing changes, and we have IV starts. That's it. I think that's it. You have a lab for maternal newborn, and then the next day we have IVs all day. We're going to just master that IV skill. So that's pretty exciting. You guys are the first class that get to do it in semester 3. But don't worry. People had been scheduled for peds, maternal newborn, and even this week, which now you don't have that anymore, but I'll make sure that everybody gets what they need in lab. And at the end, if there's 2 or 3 weeks where you don't have anything that you need to be signed off on, you're doing great in clinical, you don't need any kind of remediation or any kind of extra help, you don't have to come. You might have to come if you haven't finished up all your skills, but we'll get those done. Does that clear that part up for everybody? Okay, good, 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 good. All right, can you guys see my cardiovascular screen? Ooh, a billion chapters. Remember what I said, just outline them. You'll get the gist of everything. Does everybody have this Med-Surg book, or is there anybody that needs a Med-Surg book or workbook? Because over the weekend, Mary and I were cleaning out our offices and getting things arranged, and Student Nurse Association has their own office now. I'm proud to say we did a lot of work over the weekend, but I found a Med-Surg book that I'm willing, to help somebody with if they don't have the actual book. So stay after and hang back and let me know if you need anything. I have tons of books in my office, tons. So if somebody doesn't have a book, let's take a look and see if I can share that one with you. For central line dressing changes, the demonstration that I do is very brief. It's very few steps. I make sure that you get all the steps in, you write them down right when we do the demonstration. These are different ways that they do them. These are interesting ways. Some are better than others. Some do things a little bit differently, but what we'll do in lab, just to be clear, we'll do the cap change. We'll do the removal of the old dressing, and we'll put on a new dressing. And each student will demonstrate that. And the cap change is every single time you go into clinical and you have somebody with the central line, that doesn't mean that you're going to do their cap change that moment. But for TPN, you change it every time. So I show you how to clean the junction, remove it, clean again, put the new primed cap on, and leave it and get it ready to administer the TPN. So you have that. And these two are good. They're good to watch because it's good to watch how other places do things. For cardiovascular, like the main point for me is the blood pressure. Now, honestly, every patient that you see, the first thing you do is you do their vital signs because they're vital. You check their blood pressure. And the blood pressure is, as a refresher, is the pressure exerted on the vessels that carry arterial or oxygenated blood through the body. It begins in the heart's ventricles and affects the arteries, arterioles, and capillaries. Blood pressure is cardiac output times the systemic vascular resistance. Now, I don't believe there's one single one of you that has not taken care of a patient with hypertension. Because when I sit there in clinical and get report, I have a 58-year-old female with hypertension, diabetes, GERD, hyperlipidemia. I get that every week for 16 years. There isn't somebody that is not in the hospital that doesn't have hypertension. Many of them do, a large percentage, I should say. So understanding hypertension is super important. Now, starting nursing school, you could be pre-hypertensive. Your pressure went up. You're getting a little nervous. It's scary. You're getting this. I have never had high blood pressure. I've always been low. Many of you are athletes, and I don't know why my pressure is up a little bit. I don't know. Stress can do this to you, but we're going to talk about the different things that can bring this on. But the one main point I have for hypertension is, just like I said with diabetes, if it's not under control, if it's not being addressed, it can wreak havoc on all the other systems in the body. It can cause problems for people across the board. And it is a silent killer, especially for females, because females are notorious for putting aside like their main physical problems and problems like that to keep powering through. Many of them, it's just a societal thing where they're working, they have children, they have, careers, families, all these things that they're responsible for. So let's say there's a little pain, or you have like a little racing headache at night, and it can just be put on a back burner for saying, I'm just so busy. I'm busy all the time. It's XYZ. It's because of this, it's because of that. And it could very well be that there is a pre-hypertensive crisis going on that is not being addressed. And if you look at this grid and you can see all the things that are being affected. So just in general, it says hemorrhage, excessive sweating, inflammation, crisis stressors, exercise, physical, emotional trauma, increased body temperature, all these things, increased body size or obesity, dehydration or a high hematocrit. All these things are put out there and being discussed because why? What if you, what do you notice about the different factors that affect blood pressure? A lot of them are things that we can manage. So I have another slide. Well, this just gives you the rundown, okay? Normal, and then an increased wall thickness, that reduced interior diameter, and persistent elevation of the systolic blood pressure greater or equal to 140, and a diastolic of greater or equal to 190 is the definition of hypertension. I'm going to go to the slide where, I'll come back to those diagnostic tests. Hold on. I'm going to look for one thing. Come on. And I will go back. Now, normal 120/80. I'm hoping that most of you are awake right now. Not everybody, but it's probably a normal pressure for most all of you. I don't know if anybody here suffers from hypertension. I did probably about 15 years ago, 20 years ago. I don't have high blood pressure now, but I try to exercise every day. I try to walk for 2 hours, hour and a half. And since school started and the weather's been bad, I've been bad. So I'm getting back on that. But it's something that with exercise and like watching the sodium intake, I don't need medication because I took it for a long time. But looking at this, normal 120/80, pre-hypertensive 120 to 139 over 80 to 89. That's something that could be a tiny bit alarming that you want to get just like take notice of. And then there's the three stages after that: hypertensive stage 1, stage 2, and a crisis. So if you have a patient, we'll come back to this. I'm going to go back to where we were. If you have a patient that is pre-hypertensive in the hospital after a very, maybe a trauma, a terrible car accident where bones were broken, or maybe people died or something, just a really severe trauma, you may notice an elevation in this person's blood pressure. It could be transient, it could be under control right away or not. If you notice, if you have a patient that, let's see, in their early 40s, perhaps just started a new job that was, it's got a lot of stress involved in it, and they've got a teenager at home that's acting crazy, and they have, they're going through a divorce, a new job, the teenager that's acting, all of these factors in place, and the patient, the student, not student or patient, the person, sorry, is really struggling in life at the moment, I would say, kind of in a semi-crisis. There are things that can be done, okay? And they go to their healthcare provider and they speak to the clinician, and the clinician will say, you have a very stressful job. On your lunch break, you get 1 hour, maybe you can go for a half-hour walk, half-hour lunch, that kind of thing. You have to de-stress. You have to try to maybe help your crazy teenage kid that's acting crazy, or, talk to somebody, get some counseling, and you start there, change in diet and exercise. That would be like the main thing. Diagnostic testing, you get to the hospital, you're going to get a urinalysis, electrolyte panel and glucose, BUN, creatinine, lipid profile, and an EKG. These are the tests that you would be using across the board, and you are able to determine, well, this patient is hypertensive. This patient has hyperlipidemia. This patient has a changed EKG or an abnormal EKG, and we're going to start with interventions for that. Lifestyle modifications can sometimes put people right back on track, okay? Weight reduction, even if it's, a very small amount. Then there's the physical activity, 30 minutes a day. Give your body 30 minutes a day of exercise, of walk. We're going to come back to that. Quit smoking. You know, if your patient's still smoking and you talk to your patient, I've noticed it's really hard to be a smoker in these towns anymore. You can't even smoke in bars anymore. You have to go outside. You can't smoke anywhere on Cottage Hospital's campus. You can smoke in your room if you're a patient because some people think it's okay. It's like somebody is smoking. You can smell the smoke and smoke coming out. No, I'm not smoking. They have oxygen and somebody's lit up in their room. Okay, problem, right? Don't want them to blow themselves up with the oxygen, but smoking is really hard. Well, I'm going to go outside and smoke. I have to go smoke. We had a patient over the weekend, a few weekends ago, that said, I have to go smoke. And the patient couldn't leave the hospital. And I said, well, you can't leave the hospital without an attendant. The attendants can't leave the campus because they're working. And we're going to have to figure out something else for you, which meant that we were, just one second. This is my boss. Oh, no, that doesn't affect us. As far as the quitting smoking goes, we were able to help this patient with a medication, an anti-anxiety medication, a patch, and that kind of helped, a nicotine patch kind of helped him off the ledge because he really wanted to go smoke. He said, I will take out this IV, I will leave the hospital AMA. He was that intense. And it is serious, the smoking part. It is a vasoconstrictor. It does cause problems. It exacerbates a hypertensive crisis for sure. So there's all of those factors that we have to think about. So the smoking factor, we try to talk them through smoking cessation courses. There are a lot of resources for that. And I don't think that many people smoke anymore. I mean, they must, of course. I mean, a carton of cigarettes is, I think, $25 a carton. It used to be like $5 or $2.50 or whatever. They used to be 50 cents a box, and now they're like $10 a box. So they're a lot. Cigarettes are a lot. The DASH eating plan, what is DASH? It's this like salt substitute stuff that says it's supposed to be really good and salty. I think it tastes really bad. I'd rather just have no salt, but I love salt. So DASH works for some people. It doesn't work for me. It does help with the sodium intake, that's for sure. And it is offered in the hospital on the low sodium diets. But again, I've tried it. It smells like some weird herb that doesn't help me at all. So I have to work on the salt situation. Reduce your stress. That is again with the physical activity. And I said I'd circle back to that. Oftentimes, a lot of these patients that have a problem with a sedentary lifestyle perhaps have problem with their feet, with their knees, with their hips, and it's because of the weight. So doing the physical activity to reduce the weight can also be a problem. It's just like it goes in snowballs backward, forward. You want to reduce the stress by doing the physical activity, which would then reduce your weight, but you can't do the physical activity because of physical problems that you have. It's just it's a lot. There's a lot of factors to take into consideration when somebody is trying to do a lifestyle modification. And oftentimes we do try to educate the patient on baby steps. Maybe this patient says, yeah, I don't do much. I just stay in my apartment. Maybe just saying to this patient, I know it sounds like a lot, but if you try every day, maybe from your chair that you sit in to the corner and back every day, and as you build up your stamina, as you build this up, it might not be as difficult. And once it stops being that difficult, maybe you can go a little bit further, that kind of thing. But walking or physical exercise definitely does reduce your stress. A lot of you will say, I have to go work out. I'm not going to not go work out. It is something that is really important to my physical health. It helps me get through my day. It helps me get through nursing school. It's important. One guy that just graduated a couple of semesters ago showed us a picture of himself before nursing school, and I didn't know who it was because he was kind of chubby and hefty, and he's like, this is what nursing school did to me. And I was like, whoa. He stress ate in nursing school, and he said, it won't take me but semester not being a nursing student to get back to where I was. And I was like, wow, that was a lot for a couple of years of nursing school, but he's already on the path. He's got a job and he's doing great. So he was pretty happy with himself, but I didn't realize it was that bad. I know nursing school makes you stressy. So, and it makes some people, even if they're breaking their backs, go to the gym and work out and have sore backs, no matter, but you got to just have that like happy medium. Don't do too much of one thing or another. You just have to be kind of on the moderate side to where you're taking care of yourself. Drug therapy is a good one. This slide, I would like you to watch today while you're still thinking of hypertension, maybe in between classes or after class, because it does spell things out. It is a tiny bit over what you need to know, but it really does spell things out very clearly. Drug therapy for hypertensive patients can be, once again, especially for a student, can be very tricky when you're the administrator of the medications, because you're going to go in and the drug therapy could be new. You could be giving a hydrochlorothiazide. That's usually what's started, like a 12.5, a very low dose for a hypertensive patient to bring pressures down gradually. So it says the primary action of the hypertensive treatment should reduce the SVR, reduce the volume of blood circulating, and decrease the cardiac output. Well, the fact that a medication can be given and make somebody feel lightheaded when they sit up, it could drop their pressure right away or not at all. So thinking of keeping that in mind, you want to be the clinician that is very diligent. You want to understand why you're giving a blood pressure medication, what the parameters are. And you know what? This thing about, I took it 45 minutes ago and it was fine then, and now the patient, no. The safest way for you to give a parameter medication for a hypertensive patient, and this is a fact, get your Dynamap in there, hook up that patient right when you walk into the room. Press that button. It takes 1/2 a second while you're opening up your MAR. So you have a pressure right in front of you that is accurate. If it's way off the mark, take it again. Say, you know, I just took this pressure and it was this and now it's this. Okay, maybe your cuff's not on right. Take it again and go with that pressure. And if you're thinking, oh, wow, this pressure is super low, and I have this hypertensive medication that's going to decrease this patient's blood pressure, I'm going to go get my clinical instructor. I'm going to go talk to my clinical instructor. I'm going to go talk to my primary nurse. I'm going to report it immediately because something is not right here. Hypertensive medications, when you are giving your med discussion to your clinical instructor, remember, clinical instructors want to hear your reports chop chop. They don't want to hear this big, long, drawn out story. We've got, 5 other students to listen to. This is the med, this is why I'm giving it, this is what the side effects are next. This is the med, this is what, okay. But there should be a big star on that hypertensive medication, meaning that you have parameters. Parameters meaning you are going to check the pressure, you're going to check the apical pulse, you're going to check what needs to be checked for that medication. It isn't just, oh, I got to sign this, I wrote it down, this is what I'm giving. You need to dig deep a little bit further because not one of you on my watch is going to be dismissed for doing a med error. That's not an option for us. These medications, once again, I put on these slides so that you can be aware of the different types of medications that you certainly will be giving. These are, the captopril, enalapril, benazepril. These are all hypertensive medications. And in red, it says what can happen. What are the side effects? Dizziness, orthohypotensive, orthostatic hypotension, GI distress, a non-productive cough. That's really one telltale sign. You have losartan, olmesartan, valsartan, different medications. Just remember your considerations. You're going to want to know what that pressure is. You're going to want to know if it has a diuretic, if their I's and O's are on the level. You're going to want to know a lot of these things, all of these things in your discussion. So these are just different medications that will allow you to understand why the patient's getting an adrenergic blocker, a beta blocker, a calcium channel blocker. Keep in mind, you're doing meds every single week in clinical. You're doing 25 questions or more every single week in your practice in semester 3. You have to be able to look at a low pressor and know, okay, you may not know right away that it is an alpha adrenergic blocker, but you know it's for hypertension. You're giving an Inderal. You may not know right away, that's what I'm trying to say. Get in there and find out what it is, what your calcium channel blockers are. The education of the patient is something. Uh-oh, I see a hand up. What's up?
I was just curious, what was HA as a side effect?
Headache.
A headache. Okay, thanks.
Yeah, hypertensive medications can not only give you dizziness, they can give you, you sit up right away and you almost want to faint because the circulation's not going to the top story. A very dry mouth because it's oftentimes they have a diuretic to decrease your pressure. Trying to think of what other ones: headache, dizziness, hypotension, stomach upset, a dry cough. Somebody that's just started a hypertensive medication can be a dry, non-productive cough that is super annoying. Like you listen to somebody and they're constantly got this little tickle, this dry cough. It has a lot to do with the fact that the adrenergics dry things up. So keep that in mind. Those are all things that you may be able to discuss with your patients. So frequent urination, of course, because of the diuretic in it, but sometimes hypertensive medications, when you see here diet, it depletes the fluid, and that fluid makes you dry and almost craving salt. You want more salt if you're a salt. I see people sit down to a meal before they've even tasted it and salt it because it's just going to be better if it has salt on it. Just that kind of stuff. Sexual dysfunction. It can leave people without any kind of drive for that. So primary importance is identify, report to minimize the side effects, and compliance is a huge one. Now, you may meet patients that have started on a medication, their pressure is, iffy, it goes up and down, but reason being, they've decided that because this medication is expensive and they want to, minimize the use, so to speak, or try to maybe like not use as much, they're only going to take it every other day. They've already Googled it and it's not harmful, or, they've already gone to MD something online and their friend told them every other day is good enough. You don't have to take it every day. That way you can get a little surplus because, there's fixed income or there's copay or they're too expensive. All of these things, that has to be like one of the hardest things to break through because people can't afford things. That's one of the hardest things to teach a new hypertensive patient, that no, you don't want to do that. Stroke, heart attack is much more expensive than that pill. And then, giving things up, or maybe the other thing is too, in the hospital, when you hear that kind of stuff, and you will hear it, students have come to me many times saying, when I talked about the med discussion with my patient, they stated that it was too expensive. That's when we, as the clinician, as the nurse, as the student, whichever, talk to your primary nurse, we get the discharge planner involved for resources, meaning that we can get them on a med program. We can get, a lot of times the discharge planners have different connections and different resources that will get them into a med delivery program that can reduce their cost, or get them into where some of the physicians have surplus as far as samples that can get them, a little bit of a padding so that they have the medication that they need, that type of thing. Because, people in society are generally on survival mode. And survival mode meaning, am I going to eat, or am I going to take this medication? Am I going to pay my rent? Am I going to have gas to get to work? That kind of thing. And not everybody understands that. Not everybody understands a lifestyle like that, but there are some people that struggle like that. And we have to be sensitive to that. And we have to be able to make recommendations or to assist in that kind of a manner so that people can get a better outcome. Here it says, where is the medication adherence breakdown? 100%. Not filled, -12%, not started or not finished. This is kind of like an idea of where some people are in their, adherence. Are they doing what they're supposed to be doing? Are they complying? Then you'll have a couple that comes into the ER, both of them not feeling well. One, they're both on the same medication. Okay, maybe they're in their 50s or 60s, and the husband's pressure is perfect and the wife's pressure is all over the place. She's not taking her medicine. And you're the nurse, the admitting nurse, and you're, getting the history and you're wondering what's going on. So I am taking it. You can't be. I take it every day. Look at my blood pressure. You must not be taking it every day if that's your blood pressure. That's not true. Physicalities change, genetics change. Sometimes medication becomes ineffective. You're not getting what you need, or medications have to be changed a little bit. And maybe the female needs to be bumped up with a little more of a diuretic or a little add to the medication, a medication cocktail. And the male, the steady Eddie, takes it every day at the same time, doesn't have any problems. That doesn't mean that a person is non-compliant. That means that maybe something's changed in their bodies genetically. And talking about this, hypertensive stage 1, you're generally going to start a medication. And they're going to start it with probably a hydrochlorothiazide. There might be a calcium channel blocker involved, but a hydrochlorothiazide or HCTZ at a low dose for a while can kind of bring things to where they need to be. And hopefully in the pre or stage 1, hopefully that little bit of medication, a diet change, and an exercise modification can bring them back to where they don't need to take a medication. Okay, that would be ideal. But a stage 2 and a crisis is something that can hospitalize you and even make you, have ill effects from a crisis. Hypertensive crisis in an acute management, I've seen this. I've seen this many times. I remember getting a message from my child. Where are you? Are you out? Yeah, I'm out. And get a picture that looks like that. I'm in the hospital. I'm working, 15 drips, all these drips and all these, medications to bring a pressure down. And then once it's down, to keep the pressure where it needs to be, these vasopressors and hemodynamics that are, titrating the mean arterial pressure. What drugs need to be administered? Is their cardiac pressure functioning well? The renal function? Are there neurochecks where they need to be? All these different things. And it says determine the cause and educate to avoid a crisis. And that's kind of where you'd be in an acute care setting. Where is this patient? What needs to happen? Hypertensive crisis can be very, very serious. A myocardial infarct that we will talk about right after the break is something that is known as the heart attack. I'm sure many of you have taken care of patients. There's these blocked arteries, there's, tissue damage. There's a lot of different reasons why. It could be a rupture, it could be a blockage, could be just the plaque that's slowing things down, or it could be just severe tissue damage. So take 10 minutes, come back, and we will talk about a myocardial infarct or an MI. Guys, maybe somebody else showed up. Got somebody else that showed up. That's good. Okay. Oh, no, never mind. They're only 40. Everybody's back. All right. So the myocardial infarct is known as a heart attack. MI occurs when the blood flow decreases or stops to an area of the heart, damaging the heart muscle. And several patients that you will take care of may have had a minor myocardial infarct and not know about it, or function just fine without discussing it with anybody, so they don't say anything. It's kind of like there's kind of a stigma, like, oh, you had a heart attack, you're weak, there's a lot of different reasons why people don't talk about this. Risk factors, again, ethnicity, gender, family history, and age. Those are the non-modifiable risk factors. things we can't change. And culture and ethnicity is a big one, because if you think of the reason why you see in the Latino population or African American population, the myocardial infarcts are a little bit more increased than the Mediterranean, than the, Caucasian, is because of the diet, stuff that we eat. Now, I will give you an example. If you come to a party at my family, with my family, you'll see a huge spread of food, okay? And if you look at it, like 95% are carbs. They're all good carbs, good food, but then you'll see this beautiful salad that hardly anybody ever touches. The green stuff, it's like, yeah, that's good. All the beans, the rice, the enchiladas, tamales, all this good food that's over here, and that red meat, all of that is very cultural, okay? Well, yes, you're going to be hypertensive, and yes, you're going to be overweight, and yes, you're going to be, these risk factors are going through the roof, because nobody's trying to eat anything that's healthy during those events, those family events. That's what I will call them. Now, as the years progress and people get more educated and people try to understand, we do try to modify. We do try to say, we're going to go healthier with this, and somebody will taste it. Ew, what happened to this? Who made this? Somebody messed up on that one. That was not right. You know, if you try to do the non-fat or the lower sodium or anything that's not what a family is used to culturally, those are kind of an unacceptable thing. I mean, we do our best. That's all we can do. Okay. As far as your age, as you get a little bit older, things start changing. You can't eat as much, or you don't exercise as much, or whatever they are. These are things, you can't fight them. You can't beat it. You just have to do things differently. And if you go to the modifiable, you can certainly stop smoking. Abdominal obesity, you can try to change your diet. You can stay away from the high cholesterol foods. Psychosocial factors, maybe try to relieve your stress, get away from somebody that's an awful stressor for you. Where it says diabetes and high blood pressure, that's where we come into play. Our patients need to be educated and they need to be managed. So diabetes, we're going to learn how to be that diabetic educator in that time frame where those patients are your charge. And as far as high blood pressure, we are going to be in that time frame when you're taking care of these patients to do as much education as you can, because these are modifiable. These are things we can change. You can't change you can change your friends, not your family. So remember that. You get what you get. Signs and symptoms. Again, I want you to look at these symptoms, and we're going to do a little game, and I want you to look and see how many of these things you got before clinical. Tachycardia, where your heart's going a little faster, a little nauseous, a little dyspnea, hard to breathe, you get a little sweaty, get a little nervous. Look at those things. Does that mean you're having a heart attack? No, it means you're going to clinical for the first time and you don't know what to expect. You're freaking out. That the problem I have with the signs and symptoms of an MI are, we could get these every day. We could get some of these signs and symptoms every single day with our lifestyle, with how we're living, with what we are doing. And we're not having a heart attack. Like, I say severe chest pain. One of our past instructors was having like a tightened chest, a tightened arm. And of course, she was a nurse and she taught 4th semester for many years. She taught critical care and she was ignoring these signs. Okay. So she was modifying things in her own mind. Instead of parking so far away, she started parking closer because she was getting like a little tight chest and she thought, God, I'm so overweight now. I've got to start. I've got to get my, workout on. I've got to get in such bad shape. This is just getting crazy, or feeling like her heart pounding when she sat down. Gosh, I'm so out of shape. I got to get that again, a little bit of sweat, a little nervousness. All of these things were piling up So she started parking closer, started modifying what she was doing. Still getting to her office and sitting down for a while before she started lecture and saying, "Oh, sweaty. I feel so nervous. Gosh, I taught this thing 1,000 times." And I was like, why is my heart pounding so hard? This is really crazy. I'm just not feeling it. So then she even started coming to work a little bit earlier and having her husband drop her off. And she clearly spoke this to all the faculty and students as an in-service. And she said, and when that didn't start working and she was done teaching a lecture one day, she sat in her office. She felt like her chest was really tight. She wasn't feeling good. She called the main office, our regular director back then, and she goes, "You know what? I don't feel good. Do you think you could give me a ride to the hospital?" Well, of course, in 6 minutes, she was at the hospital ER, and she was having an MI. And she was in the hospital for a week, and they did do some stents. They did some work. They did some help, and she had to do cardiac rehab. And she wants to say that these symptoms were going on for at least the end of one semester, so in December, through March. So started at the beginning. So maybe half a year, like getting these little like triggers, getting these little alerts, where the light goes on in your car. She had all these lights on and she wasn't doing anything about it because number one, she was a nurse. She thought she was fine. She's like, "Oh, I'm just going to change this. I'm just going to do that. I've raised 2 kids, been working at this college for 25 years. I know what to do. Just park closer. Yeah, I'm not in great physical shape, but I can start walking next week. I can start blah, blah, blah." It was the wrong thing. These are silent killers. A heart attack can kill you. Okay, you see the little elephant. It feels like you're getting your chest crushed. These pains where you have neck, back, substernal pain, jaw, shoulder, or you'll say, oh, I just slept wrong. I'm just gonna, work this out. Or this tightness, oh, it's indigestion. I ate too late. I got the kids all ready for school. I got all the bills paid. I put away all the groceries. I did blah, blah, blah. And now it's 11:30. I got to get to bed. I'm just doing too much. I'm having indigestion. That's what people do when they're in this denial mode. Okay. So all of those things came into factor for this person. And when she went into the hospital, she got, of course, a 12-lead EKG. They did a cardiac catheterization. Her troponin levels were off the chart. It's specific to your cardiac tissue. And it'll tell, if they're elevated, what's going on. There's been an insult to that area. All of these things were done. And she was definitely actively having an MI. Immediate treatment. They give morphine, they give oxygen, morphine for the pain. And it's also decreases the constriction. Oxygen. Nitroglycerin is a vasodilator. And then the Plavix or the aspirin to kind of help to clear any blockage. So you see, initiate an IV access. They do their blood, they initiate IV meds, they give morphine to help with your breathing. It's kind of, relaxes things down. You're taking in that oxygen. For the nitroglycerin, it says, what do you need to find out first? What their lab results are first. Continuous rhythm monitoring. So they're put on the monitor. We're getting, reading that monitor in a constant, you have a constant pulse ox. It's to see the patient's getting oxygenated. And then the anticoagulants, and there's different types. The aspirin they take right away in chest pain, they stay out in the field, chew that aspirin, that baby aspirin, and hoping that, it can start the process of clearing things up. The myocardial infarction in complications or death, arrhythmia, rupture, tamponade, failure, valve disease, an aneurysm of a ventricle, the Dressel syndrome, an embolism, recurrent myocardial regurg. Oh, hold on 1 second, you guys. I'm sorry. Hold on. Sorry, that doesn't have anything to do with us. So yeah, this Dressler is like the inflammation around the sac of the heart, an embolism, or a mitral regurg. That's something where the circulation is backing up. It's not going where it's supposed to go. Lipid lowering therapy. You know, people think that that isn't a big deal. It is a big deal. That is really gross. We don't want to have to look at that. But the statins, one point to make with patients taking the statins is they can have a weird side effect immediately. You give them the statin and you're still in the room, you're just documenting active, and they can instantly turn beet red, like red instantly. It's really weird. And some people just say, oh, don't worry, I only stay like this for like 6 or 7 minutes and then it goes away. Well, it's pretty freaky. It's pretty weird to see somebody go from regular color to beet red, like they just ran around the block 5 times in, a few minutes. But the statins can do that. And some people for that very reason will not take them. They just won't take them. They'll try to figure out something else because it is an uncomfortable, weird feeling that people don't want to try to do. They're just not going to have it. Some people just say, don't worry about it. It's not a big deal. You're going to see me turn red in a minute and it goes away. I'm not worried about it. But which food should be reduced? High fats, of course. Those are the fatty foods that need to be reduced when you have, lipid lowering therapy. The statins are the meds, niacins, fibric acid inhibitors, omega-3 fatty acids, the biosequestrants, and then cholesterol absorption inhibitors. Some physicians will try the statins first. Some people are very allergic to statins. Again, there's reaction and allergy. Some people get, closed up throat. They're not going to take statins. Okay. Something else has to be figured out because lowering your lipids isn't an easy thing. And it's hard to say who's got this problem because I can tell you that there can be an instance where a female has scarfed up, just eaten everything, fatty foods, had perfect cholesterol. And then there's the person that's in their late 60s that walks every day for 1 hour, that never eats anything with fat in it, stays away from it, and they have the MI. So it's just the cards that you pick. I think oftentimes it just depends on who you are and how things are going to play out. But definitely, it's a definite thing that it is genetics. It is who you are. It is lifestyle. Modifications can work. They may not work. Medications might be in order. They may not be in order. Everybody's different. For you as the student nurse taking care of these patients, you have to know what they're planning. Because I know every single one of you has given report and said, I have a hypertensive diabetic with hyperlipidemia, GERD, and a broken ankle, whatever, renal failure, all of these things. Well, there's treatments for all of these things. And a lot of these patients need to have education, and they need to understand what's going on with them and why they're taking what. Oh, I take that little white pill. I take that little brown pill. I take a blue pill once in a while when I'm feeling this. And they may not have the proper education that they need for their meds. So it's something to think about. Heart failure, the definition is an abnormal condition that causes impaired cardiac pumping, impaired efficiency, inability to handle the volume of blood, characterized by dysfunction, reduced exercise tolerance, meaning you can't get from point A to point B without being completely short of breath. It diminished quality of life, and it does shorten your life expectancy. So you can see in the picture, stiff and thick chambers, stretched chambers where the heart can't pump. If the heart's too big, it's a muscle and it can't pump. 4 stages of congestive heart failure. You have the stage 1. You're breathless, tiredness with a brisk walk or jogging. You can't take a flight of stairs. And people understand how to modify this. People understand what it takes to do modifications to where they can get by. Stage 2, you're comfortable when you're resting, but your heart races and you become breathless when you do any of these little things. Okay. Then stage 3, palpitations, tiredness with simple tasks, getting from the sofa to go get your mail outside can cause a problem. And then stage 4, heart and breath go faster even at rest. Tiredness even while sitting. You have anxiety, palpitations almost all the time. You have to sleep sitting in a chair, sitting up, because lying down can cause even more problems. These are congestive heart failure. Heart failure risk factors, coronary artery disease. So the hyperlipidemia, you have the disease where there's plaque in your arteries and you're not functioning to full capacity. Older age, older age is a privilege, but tobacco use and obesity bumps up those factors, and some things overlap. Coronary artery disease cause diabetes, can cause that, high cholesterol, hypertension, and ethnicity. The African American population and the Latino population, they definitely have a higher risk factor involved. Heart failure compensation, increased heart rate, activates the sympathetic nervous system, less blood flow to the kidneys. So we're going to talk about that. We have a whole unit on renal disease, renal problems, renal insufficiencies, increasing the conversion of angiotensin 1 to angiotensin 2, increased vasoconstriction, and an increased blood pressure, meaning that those renal arteries are being affected. Less blood flow to the brain. Increased ADH, the antidiuretic hormone, causing the fluid retention. So you'll see these patients, and I know you've seen those legs when you go to do your assessment and you're like, whoa, what is going on here? There's, 1, 2, 3, 4 plus edema, and the edema is, we want to get those pneumatics on. We want to get the AE hose, anti-embolism stockings on. First thing, that's why getting in there and getting your assessment done, getting those stockings on them before they hang their legs over, so that dependent edema doesn't get worse. Endothelial activation, it causes the vasoconstriction. So the heart, the endothelial tissue in the heart is not working on the right, it's not firing correctly. Cytokines released from a myocardial injury, it accelerates the hypertrophy of the heart. So all of these things are causing damage to the heart, interruption to the heart, to the nervous system, and the heart's doing its best to work for you because our heart's pumping all the time, and if it's not, we're in trouble. We do the BNP test, a cardiac echo, and an MRI to see exactly where the problem is. Now, you're doing a CT scan with contrast, and you're looking at where the dye is going, what area in the heart is malfunctioning, and these things are done in the specials lab. You'll do the cardiac echo, and when they're in those labs and you guys have them as patients, go with them. If you can go with them, go watch the test being done, because you can see on the screen the areas that are being affected. Now, I'm not to say that you have 2 patients and the other patient is very hands-on and very busy. Sometimes you won't get the opportunity, but a lot of times your patients aren't that busy at certain times. And if a patient goes for a test, discuss with your clinical instructor, this is what we've gone over, we're studying this, and if I could, I'd like to go to the specials lab with my patient. Sometimes it's a huge comfort to the patient to have somebody with them, okay? Going into the specials lab as a student can be kind of, eye-opening, and sometimes they'll try to get you involved and you don't have your instructor there. That happened to me as a student. That was kind of rough, but there's a lot of things that you can see, and it really is an interesting thing. We have right-sided and left-sided failure, and it shows you here for right-sided heart failure, mostly caused by left-sided heart failure, cor pulmonale or right ventricle MI. Then it says congestive peripheral tissue, blood backs up in the right atrium and the venous systemic circulation. You go through and it says liver congestion, signs of an impaired liver function or hepatomegaly, GI tract congestion, anorexia, GI distress or weight loss, and then the appendant edema, meaning in the legs and extremities, arms, or ascites, JVD, jugular distension. That's something that you can see on the right, on the left, mostly caused by LV dysfunction, MI hypertension, coronary artery disease, or cardiomyopathy, meaning death in some of the arteries in your heart. The blood backs up into LA and the pulmonary vein. So you're looking at the left heart failure, decreased cardiac output, pulmonary congestion, impaired gas exchange. I read this so much on, I don't that much anymore in care plans, right? Impaired gas exchange. And there, a lot of times students aren't understanding what they're meaning by it, but you do see poor circulation, poor blood return in the, fingertips, or you're seeing, cyanosis, signs of like a little bluing, or a little fingertips or toes are feeling, are a little hypoxic, that kind of thing. That means there is an impaired gas exchange, and that is definitely cardiac. The pulmonary edema, they're short of breath, they're tired all the time. You're listening and you can hear, crackles in the lungs. They're coughing up all this frothy sputum, and you have to hear that coughing up of all that, and that makes you kind of gaggy. That makes me gaggy listening to sputum. But the major goal is to reduce or to prevent this pulmonary edema. So you're trying to pull fluid off. You're trying to, decrease the secretions and help them get that out. There's a lot of different things to heart failure, and right and left sided, it kind of spells it out in this picture. It's a really good picture. It says, as you study the cardiovascular systems, it helps to know how the blood flows through the heart, and you can see where it goes through, non-oxygenated, becomes oxygenated through the lungs and goes back into the circulation. And I know in semester 1, you did the circulation of the heart. You do it with the infants too, but it is good to know how that heart pumps. Treatment, pump it, park it, pee it. So the treatment for heart failure, improve the myocardial contractibility. And a lot of times that is done with the medication. So you do it with the DIG, and it helps the contractibility of that muscle. The beta-adrenergic agonists, or the dopamine, or the inokers. And then you do know that when you give DIG, you're going to be checking an apical pulse, because there are parameters for that digoxin you want to check to see where their levels are and if it's something that can be given. Reducing the cardiac workload. The heart is tired. When your heart is in failure, it can't pump your circulation well. So you're going to give oxygen. You're going to promote rest, physical and emotional. That is a big thing, because that lets your body release a little bit, slow down a little bit. You're going to administer your meds. You're going to do the ACE inhibitors, the ARBs, nitrates, beta blockers, and administer morphine, which reduces the preload and afterload, because it smooths the smooth tissue down. It decreases the contractibility of the smooth tissue. It allows this patient to have like a little bit of a relaxer, but not too much, because then that can decrease the ability to, your respiratory system decreases in your ability to oxygenate yourself. So, and then PIT, correct sodium and H2O retention, volume overload. So you're going to definitely administer the diuretic. Now, all these different meds in this combo for heart failure, pump it, park it, pee it, can cause a problem, because the diuretics, the thiazides, the hydrochlorothiazides, or the HCTZ that we talked about as the primary for a hypertensive patient, has the diuretic in it, the loops and the spironolactins. They pull fluid off, which will make that pump not work so tight, work a little bit easier, and hopefully the contractibility with the first medication will allow that pump to be functioning on a better premise. But it can also cause problems. And when you're in the hospital and you have a patient on tele and they're getting these diuretics, they're on tele because we want to make sure that the heart is functioning properly, and they can have problems with that. So you're looking at all these things. There's the potassium sparing diuretics. You want to make sure you understand which diuretic that you're giving and what to be looking for. For a heart failure teaching plan, exercise, diet, and support, fluid intake, and med compliance. So we look back. These are all, this is kind of a general plan of care for the patient. And it says here, this is your teaching plan. So in looking at this teaching plan and your newly, spelt out concept maps, these are really key for this type of patient. you want to look at this. What is their support? Is it family support? Is it spousal support? Or is it community support? Do they live in the nursing home, and is that that staff supporting this patient who has heart failure? And then their diet, are they choosing the right things? Are they eating the right things? Are they using that awful DASH stuff that helps with, the sodium? The exercise, are they able to get around? Are they able to manage very simple ADLs, meaning like walking from here to the door and back? Or do they do 2 or 3 times a day a slight, exercise plan where they could be, let's say, walking around their unit if they're in a nursing home, or if they're in the hospital, walking around the unit once with assistance, a standby assistant? Are they kind of limiting their fluid intake so as not to become fluid overloaded? Now remember, med compliance, where you said pump it, park it, pee it, those diuretics pull fluid off, which in your brain causes that thirst factor to sit up and say, hey, I'm really thirsty. The more you pull off, the thirstier I get. I need something to drink. And there's different ways, and we talk about it when we have a renal patient who is a fluid restricted patient. Fluid intake has to be kind of, decreased. Now, the second you tell a brain that you can't have anything to drink is the second that you become extremely thirsty. Extremely thirsty. Now, you're going to go to surgery. They say nothing after midnight. Who drinks after midnight? Raise your hand. Nobody. You're usually asleep after midnight. But the second you're told you can't have anything to drink after midnight, you wake up at 1 o'clock in the morning and you're so thirsty. You're sure you've got to have something to drink and you can't have it. And you're feeling so deprived and so restricted. Well, fluid intake for heart failure is an important one because they are fluid restricted. They do need to restrict their fluids, and it is very important to do that teaching. So one of the tips that we use for patients that are on definite fluid restrictions would be, good. Let's say they can have a liter of fluid a day. That's a lot of fluid, but some of you drink those bottles, those gigantic bottles that you set a big jug on your desk and you're drinking all day. I got to go to the bathroom. It's great. It's healthy, but for these patients, not so healthy. So we would tell them when I worked in dialysis to grab a large cup, a large plastic cup, and fill it up with the fluid that you're going to be drinking. Could be water, could be Crystal Light or something. No, that's not great for you. Whatever it is you're going to be drinking, and freeze it the night before. So you have a couple of frozen. Wrap it in your paper towel or your cloth and set it down. As it melts during the day, you get to sip on that. And if you let your mind forgets about how thirsty you are and it's melted a little bit, you get to have a nice big gulp. And all day long as it's melting, you're not thinking, your brain's not saying, I am so damn, I need to have a drink, and you chug it all. And then it's barely 1 o'clock and you're all out of fluids and you don't get any more. So it's just kind of one of these little tricks that you give these patients and tell them, if you freeze it, you can be a little more compliant in your fluid intake. And then, of course, the med education. A review of the heart failure, again, the inability for the heart to pump the blood to the body. It affects millions of patients in the US. About, 500,000 new cases are diagnosed in the US every year. Nearly 1 million are hospitalized, are attributed to it each year. The heart failure include heart attack, high blood pressure, and diabetes. Well, we know that the majority of our patients are hypertensive diabetic. And that's why these are the first 2 units that we talk about in semester 3. So hypertension and diabetes are most definitely problems, conditions, diseases that we take care of on the daily when we're in clinical. The symptoms, of course, shortness of breath, fatigue, swelling of the ankles, all of these things. And then they're diagnosed again by, you go in, you have an EKG, you have an echo, they do cardiac catheterization, and they start your plan of care. So here, treatments include meds, the VADs are the ventricular assisted devices, cardiac transplants for heart failure, a nurse that we worked with for quite a long time's husband, who was a highway patrol officer and a sergeant. He just got a cardiac transplant and is doing great. It was just like so shocking that it happened so quick, and he's out and about, out to dinner already. He does get tired very easily. He was at Cedars, he got his heart, and it's quite a miracle. When I worked at Ronald Reagan, UCLA, that summer with students, we were in the cardiac thoracic transplant unit with semester 1 students. That freaked me out. And these patients were sick and scary, but they got heart transplants, they got lung transplants. It was just such a trip because we don't have that at Cottage, and I grew up at Cottage. I don't know anything else than that, but we do take care of these patients. We don't do these surgeries at Cottage, but they come here for a broken, fractured hip or something like that. We take care of them and their history of a cardiac transplant. One thing to remember with patients with transplants is they take every day at the same time, or should take every day at the same time, their anti-rejection medication. And that is something that can't be late, because rejecting an organ is a big mistake. It's a horrible thing. We'd never want that to be on us. So we want to make sure you keep that in mind when you see transplant. They will be taking anti-rejection meds, and that isn't optional. That's something that has to be handled. It says half of these patients die within 5 years, 25 are discharged and readmitted within 30 days. So they're readmit. So heart failure is common. It's a common question in ATI. It is, that's for sure. And in NCLEX. So important to understand about a patient with heart failure. Peripheral artery disease and peripheral vascular disease are also, I know you've seen feet like this and legs like that. That leg on the right for the peripheral vascular disease always freaks me out, because I always think, can't they just put like a little moisturizer on those legs? Or you want to it's kind of good that we wear masks now, because when you take AE hose off patients in their beds and all that skin starts flying around, that's really gross. That happens. Keep yourself, safe. You don't want that funky stuff all over you, but it does happen, and you're going to be around this. It says related to peripheral artery disease, related to insufficient blood supply to the area. It's causing ischemia, decreased pedal pulses. And you see there, they don't have good circulation. They don't have edema, but they do have smooth, shiny skin with the loss of hair. Dependent rubor, their nails are thick and brittle and weird. They don't look normal. Intermittent claudication. So, they're having different, that foot is so classic of what these vascular disorders portray. And same thing with this peripheral vascular disease. Pedal pulse is normal. They do have capillary fill, but the edema is present, or their hair is present, but it's thick, hard skin, and it's brown and kind of scaly, and it's kind of taut. The nails may be normal, but their legs are sore and achy when you go to give the bath, when you help with their bath. Related to pooling of blood, causing increased pressure in those veins. So the increased pressure, the blood is just sitting there. That's why get those patients cleaned up, get them moisturized, and get those percussion. What is the word? Help me, somebody. Their pneumatics. Get their pneumatics put on. And there's a place on those charts on your chart that shows they need to be on. And if they're off, there needs to be a reason why they're off. It could be a patient refusal, but you have to go back and chart, because that's something that is being looked at by quality assurance. Those antiemetic hose need to be on and working, not just on and not turned on. And some people like them, some people really don't like them. Risk modifications, what would you teach, you guys? For these vascular disorders, we talked about several of them already. Lifestyle changes would be sedentary, would be diet changes, would be making sure they're taking their medications, all of these things. So those are modifications. But then it says the drug therapy, you have the Plavix or the aspirin. There's a lot of medications that are given for these disorders, and in a transient set, let's talk about that off to the side. Patients that come into the hospital that are going to be lying in bed for days at a time, all of a sudden, what are we giving them? What are we checking and what are we giving them? They never got it before.
Something to
Lovenox or heparin.
What is that?
Lovenox.
Lovenox or heparin, we're giving that because we're trying to decrease the risk factors that can be involved from post-operative patients that are laying still, trying to recuperate from that insult to the system. But you're checking. The first thing I ask you, they say that the meds are, oh, I'm giving Lovenox. Oh, what's the platelet count? I want to know what that is. You're going to be giving those meds and you're going to be understanding why you're giving. You're going to say the patient is sedentary, the patient is post-operative, the patient is post-trauma, the patient had a stroke, different reasons, but they're in the hospital laying in a bed. Sometimes you'll do the teaching where they give their injection at home as well, because that upon discharge, they're not where they need to be, so that Lovenox gets continued. You've seen that, haven't you, where the patients go home giving their own Lovenox. So maybe that day when you're going to go give the Lovenox, the primary nurse says, wait, let them demonstrate that they know how to do it. And it could be, you know, that therapy could go on for a little while. Again, surgery, when would this be recommended? When an artery is completely blocked and they have to go in and maybe put in the screen. They have to go in and debulk that big clot, get it out. Exercise when it's indicated for those vascular disorders. And at times you'll see those legs that I showed you in the previous for the peripheral vascular disease. Sometimes it's too painful for them to walk. Get those anti-embolism stockings on and have them go for a walk. Again, a double-edged sword, because oftentimes those toes are so sensitive, those nails are hitting shoes, they're unable to cut them themselves. They have to go to a podiatrist so that they don't, you know, nick themselves or cause a problem. And even then that can happen. And an infection can pull there, the circulation doesn't support, and they start losing toes. So there is so many factors involved in all of that. And then of course, a lower lipid, lowering their diet and their fatty foods. These, again, not just the antiplatelets, but also the hyperlipidemic medications as well. Medications affecting the coagulation, anticoagulation interferes with the clotting process. Coumadin, sub-Q or IV heparin. We give subcutaneous heparin all the time in Med-Surg. The only time a Med-Surg students are not allowed to regulate heparin pumps. If you have a patient that's on a heparin pump, you're obviously going to assess it. Please listen carefully. You're going to assess it and you're going to report it. And when you give the report, you're going to say the primary nurse is managing that heparin pump. You're not going to regulate it. You're not going to change parameters or anything on the heparin pump, but you're going to research it. You're going to know why your patient's getting that heparin pump. They be on a heparin pump and they may have a clot that they're trying to dissolve. There's a lot of different factors, but you certainly will be giving those subcutaneous heparin injections, and you need to know how to draw it up. You need to know how to change after you've used the access cannula, you need to know which needle to put on it. And if you have any questions on that, please bring it to my attention in the lab, because you're going to give a lot of heparin this semester. You're going to give a lot of sub-Q heparin, and we can just do a quick little demo on that and show you exactly what to do with the heparin. So if you want to bring that up on Friday, let me know. For the heparin, it's IV or sub-Q. For the Coumadin, it's PO. The onset for the heparin is immediate. And for the Coumadin, 3 to 5 days. Heparin, you're checking the PT and the APTT, and the antidote to reverse it would be protamine sulfate. For the Coumadin, you're checking the INR. If you're giving Coumadin, you want to check the INR. It gets reported every evening about 5 o'clock if a patient's on Coumadin. I honestly, in the last few years, haven't seen many patients on Coumadin. I think too, because there are other medications that are easier to manage and they don't need blood draws as often with other medications. So like the Eliquis and things like this, that they aren't using that medication, but vitamin K is the antidote for that. Antiplatelets, they prevent platelet aggregation. So orals would be aspirin, Plavix, Trentol, IV, Riopro. These are just different treatment plans for different types of patients. And then it says study hint, memorize this chart. Just understand your heparins, your coumadins, your antiplatelets. Just understand that anticoagulants are necessary in the hospital and we use them. I'm going to come back to these questions. These are just little quizzy questions that we put on here for digging deeper. I definitely want you to listen to our Southern Belle. I know you have a little bit of time because we have been finishing a little bit early, and it's really hard to get you guys to be able to hear these while we're in class, but I want you to listen to them. These medications will pop up in your weeklies, but the myocardial infarct and the heart failure, she is very thorough. Is her voice pretty annoying? Kind of, it is. I'm not gonna lie, it is. But she is definitely worth listening to. Go through these little questions on your own, and we will definitely come back to them. How's that? I will do that for you. See if you got them right. I'm gonna go to our hematology. Where are we? Talk about our blood, and we're going to talk about our administration. Oh, I don't know why it says the screen sharing was stopped. Hold on. You guys can't see my screen now, huh?
No, we just see you.
Sorry. There you go. I don't know why it stopped it right away, but let's make that right. So we're going to talk about this, and this is a skill, and this is one that we give a little bit of time to. It is 9:45. Take a quick little breakfast break, and we'll start back up at 10. All right, we're right back here for hematology. Hematology is kind of an interesting one. Not too many chapters because there's not that much about it. But as a review, we have the plasma, red blood cells, white blood cells, and platelets, and you guys can administer blood. A semester 4 student gave blood the other day, which was really exciting for me because she got written down in the blog that she knew every single step. And that, my friends, can be a free response question of administering blood. How does the SBCC student administer blood and all the steps? So that's bullet points, and that's a really good thing to remember. Deficiency of the red blood cells or hemoglobin in the blood resulting in the diminished capacity for the blood to carry the oxygen. So oftentimes if someone presents in the ED short of breath, they'll do an H&H right away to see if that patient is anemic. Usually female from the age of like 14 to 19 who have a very heavy menstrual cycle and is a bit, short of breath, and they're not sure, they get brought into the ER to urgent care and they get their blood tests and they're very anemic. And oftentimes what will be the plan of care for those patients is to put them on a birth control pill if they don't have the risk factors for a birth control pill, so that they don't bleed as much, and in not bleeding as much, their hemoglobin and hematocrit increase on their own. Anemia is a hard one in the clinical setting sometimes because there are religious beliefs that you are not allowed to have blood products. And for that very reason, you have to sign a waiver, because if you don't sign a waiver, and let's say you're in a position where your hemoglobin and hematocrit are life-threatening, the clinicians will give you, and you're not able to consent or whatever the reason being, they will give you blood. And if you don't want blood, then there's a problem, right? If you're not allowed to have blood because of religious beliefs, there's a problem. So you always want to respect that somebody has that religious belief, and it will be on their admitting papers. You sign a conditions of admission and it will say, I do not accept any blood products. There was kind of a controversy about albumin and the fact that it does have some blood products in it, but there was some kind of a little caveat that said that the patients that denied blood products, that's the right word to say, that their religion did allow them to have albumin, which would be, we'll talk about albumin as well. But so it's kind of a thing where, you know, you're really going to be put in a situation where you have to be very aware of people's wishes. And anemia etiology, how does it happen? It's the decreased production of red blood cells, and it could be deficient nutrients like iron, vitamin B12, or folic acid, decreased erythropoietin or a decreased iron availability. So for that decreased red blood cell production, your body is not making the erythropoietin, and there is a medication called Epigen. It's a subcutaneous injection. It's an expensive little tiny vial. Last I checked, it was like $3,000. It's very expensive, but it is most definitely a life-saving medication. It's life-saving. It's changed people's lives, and life-saving, life-changing. This erythropoietin given subcutaneously, and a lot of dialysis patients that are on hemodialysis will get this Epigen or this erythropoietin supplement 3 times a week to keep them alive. And there is destruction with hemodialysis of the red blood cells, and people get very anemic and they can't keep going in and having transfusion after transfusion. But this medication of Epigen, it's from Amogen is the company, it enhances the red blood cell production, and it really makes patients feel well. Because when you're anemic, you feel very, very tired, very, like you can't catch up, like you don't sleep well, you're very tired. When you've slept 8 hours and you wake up and you're still very tired, your oxygen level is probably, your saturation level is probably low, in the low 90s, maybe high 80s. And that's, you know, you can live with it. You can live like that. You can be, you know, your body can acclimate to that, but there can be a point where it becomes quite detrimental, where it could be life-threatening. I had taken a blood test because I don't know why, I don't go to the doctor very often, and years ago. And the doctor called me and said, "Are you driving?" And I said, "Yes, Daryl, I'm driving. I don't have a driver." "Well, you shouldn't be driving. What are you talking about?" Like, well, I thought there was an accident because the doctor was my friend. And he said, "You have a very low hemoglobin and hematocrit, very low. And I need you to come in right away or go to the ED, blah, blah, blah." I said, "Daryl, I've been like this for a long time. I'm not rushing into anywhere. I'll come see you on Monday." So we went in, got worked up and got all that. And I had to get like these iron treatments where you've seen that sucrose in the bags. Those, it looks like a little bag of Diet Coke. That's what I would call it. And I go and got those iron treatments, blah, blah, blah. Finally had a hysterectomy and never, you know, had a low hemoglobin or hematocrit. My point of that is you can walk around like that and not know it. I mean, when you have 5 jobs, sometimes you get tired. When you have, like, you know, a couple of kids and they're wild or whatever, you get tired. You don't think of it. When you're working all the time, you're taking care of all sorts of different people and students, and you're just a busy person, you could generally be kind of tired. But to have a hemoglobin of 6 is kind of scary and not know it. So opening the eyes, white, they aren't pink. I didn't know I was that anemic. I was pretty anemic. So getting treatment for that is an important thing. Then it says here, how does it happen? Blood loss. You could have a chronic hemorrhage, like a bleeding ulcer or colon cancer, excessive menstruation, that's a very typical one, and acute trauma. If you have an acute trauma, oftentimes you'll be taken into the hospital, let's say a motor vehicle accident or a fall where you're having, you know, extreme bleeding, okay? And you go into the ER and they get blood O positive and just put it in the rapid infuser and start giving unit after unit after unit before you've even been type and cross matched, because that is a life-saving measure for an acute trauma. Here is a red blood cell destruction, sickle cell anemia. Medications can cause that, the methyl-dopa. Incompatible blood, getting blood that doesn't agree with you, that can cause, or again, a trauma like a cardiopulmonary bypass that can harm your red blood cells and cause you to become very anemic or very low H&H. And you do know that in an immediate factor, you go into a healthcare provider and they draw your blood. Always draw an H&H. They always have to see what a baseline is. When you have surgery, that they want to know what they're starting with, because obviously a surgical procedure is going to cause an EBL, and an EBL stands for an estimated blood loss. You are going to have a blood loss. It may not be very much, or it may be a lot, but they have to have a baseline first to know what they're starting with, because if you're severely anemic, they are not going to do surgery on you until that blood level gets brought up. So in my case, they had to give me those Venifer treatments, give me an injection that put me in menopause so I would not have a period, all this weird stuff. And finally, I was at a level where I could have the surgery and fix the problem. Super weird. That sucrose, that iron sucrose that you guys probably have given in clinical and will be giving, it was so weird. It was so painful going in, and it made me feel so sick. And then the next day I'd be like wide awake and all like rejuvenated. It was weird stuff. I don't do well with any sort of medication, so that was weird. But those are treatments. Those are plans. Signs and symptoms, really the key one you'll see is the shortness of breath. That's usually the telltale sign that somebody is anemic. Digestion, you could have a slower digestion, change in the color of your stool, your muscle pain because you're not getting good circulation, fainting and fatigue, that's oftentimes a sign. Chest pain, like you feel like you're having a heart attack. Excuse me. Skin enlargement, and then the yellowing of the skin would be more like because there is liver involvement. You're not perfusing enough blood. Your H&H is low. Types of iron deficiency, nutrition types, and the treatment would be 30% of the total iron needs to be heme iron, found only in animal tissue. Sorry, vegans. Well, one vegan that I used to work with at the hospital was having problems with her vision. And she went through all this testing and whatnot, and they finally told her, you are so iron deficient that it would be in your best interest to try to eat, meat products, because she tried everything else. And it's pretty scary in your 50s to start losing your sight, and that was what they came up with. Now, I don't know how long she ate meat because she hadn't eaten it since she was a teenager and it was really freaking her out. She didn't want to do that, but it says 2 to 10% of non-heme iron can be found in plant food or meat. So maybe that was part of it. Best iron absorption boosters are meat and supplements and vitamin C. So the treatment would be the PO iron. One thing you would tell your patients if you're starting on PO iron is that it can be very constipating. It can turn your stools black or dark. That freaks people out. Constipation freaks people out. So sometimes they will take an iron with a stool softener so they don't get stopped up. The ferrous sulfate, 3 to 324 milligrams, which to me really bugs, because why is 324 and not 325. That just doesn't, that's kind of lame, but that's what it is. And you'll give that in the hospital. Best given an hour before a meal so that you get better absorption of that. And it says can also cook with a cast iron skillet for extra iron intake. That also kind of freaks me out. I just use a cast iron to warm tortillas, but that's kind of weird that you would absorb that iron from your pan. But just some point fact that I found. A folic acid deficiency, why? Needed for red blood cell formation and maturation, required for DNA synthesis. Causes could be, again, malabsorption, malnutrition. The malabsorption part, you'll see a lot with bariatric surgeries. And then ETOH abuse, anorexia, and medications. These things are all targeted to maybe the homeless population because of their malnutrition. They don't get the proper nutrition. They're not absorbing. Alcohol abuse, the anorexia, the fact that they're not eating, and then medications, lack thereof, or the wrong medications. And then treatment would be PO folic acid every day, a mild 1 milligram, for a more severe 5 milligrams. Well, sometimes people that carry these symptoms or have these, don't comply. They're not going to try to take these medications. So thinking of that, the folic acid deficiency is something that can be treated. Pernicious anemia, signs and symptoms would be a beefy red tongue, and then also the cracking around the mouth, hypoxemia, pallor, paresthesia, and a poor balance. Causes, again, malnutrition, a decreased folic acid, lack of intrinsic factor. You can't absorb your B12. Complications for a gastrectomy, somebody that has had their stomach removed or has an atrophy in the gastric mucosa. So that could be, different types of surgeries or cancers. And then here it says parenteral or intranasal cobalamin, 1,000 milligrams daily for 2 weeks, may be needed every month for life. So for a pernicious anemia, you would be getting, maybe injections or that nasal, that intranasal cobalamin. That's an interesting treatment. Aplastic anemia, hypoxia, fatigue, hemorrhage, increased susceptibility to infection, and it could be caused by toxins like surrounding toxins, environmental, medications, viruses, or radiation exposure. And that's one that could be because of a different problem you had or an exposure that you were around. And when you're in the hospital and you work anywhere near like it's not the Cancer Foundation anymore, but there's this area in the hospital, and I'm trying to think of what they named it. Nuclear medicine. You have to wear like a little dial that kind of measures the amount of exposure you get. And if the dial changes at any time, you'll have to be worked up, and they'll have to figure out where, that exposure is being taken place. Pancytopenia, a decrease of all blood cell types, RBCs, WBCs, and platelets, and it's a hypocellular bone marrow. So you want to be very, I don't know, if you see aplastic anemia on one of your patient's diagnosis, you want to understand that it says if it is a pathological condition in which the body does not produce enough red blood cells, well, there has to be ways of treating that. There's different plans of care for these patients. For hemolytic destruction and hemolysis of the red blood cells that exceeds a production at a rate that should say that exceeds production. Well, this happens for chemo patients. Chemo patients that are getting a certain type of medication can have this destruction, and it's the lesser of both evils. So in one fact, it's destroying the cancer cells, but in the other fact, it's destroying good red blood cells. So, taking care of these patients is kind of like, they're just trying to balance out the treatments. Intrinsic hemolytic anemia, sickle cell anemia, we talk about thalassemia and erythroblastosis vitalis. So these conditions will cause this type of hemolytic anemia, and definitely this is the best plan of care would be the blood administration. So talking about that, and we do talk about it in oncology. We will talk about it more in pediatrics when we talk about the sickle cell patient, but we talk about it now too, and things cross over for both classes. But the blood administration is something that it's a required skill for third semester. It is, you will know that you'll never be giving blood by yourself. As a, excuse me, as a nurse, you'll always have backup. You'll always have somebody else to administer the blood with. So you're not just going to be walking in, oh, I've got blood, here I go. It says you must know timing of giving the blood in clinical, and what you're going to do before the blood arrives, and what you need to do to set up a room. You must know the types of possible reactions. We'll go through every one of those. Be prepared to write out a sequence of blood administration. That is a free response question for this quiz. And you can practice with blood tubing, and there is a binder with the scales, but we do that in clinical, so you don't have to worry. The only problem with her and her blood administration is that hair that's all over the place. She's super sloppy on that. These are the types of components that we would be exposed to. Red blood cells are really the only thing that a student can actually administer with their nurse. Whole blood is rarely used, but all these specialties, the platelets, fresh frozen plasma, and the cryoprecipitate, they are so delicate and such, I want to say they're not just so delicate, they're very hard to get. They're a very specialty transfusion, and you can always take part in it to be observing and understanding, but actually the handling is something that we kind of try to not let students do, because we don't want anything to happen. We don't want anything to happen. If something goes awry, we don't want anybody to be responsible for that, because they are very delicate and fragile and kind of hard to get. And platelets, oftentimes when there's a shortage of platelets, the hospital ethics committee has to go through and figure out which patient, which diagnosis, which signs and symptoms deems the patient eligible to get those sought after platelets. I mean, it is really something to try to understand, because there could be a patient that is, you know, got non-Hodgkin's lymphoma, getting treatment with 0 platelets and needs to get a little more platelets to give a little more preservation of life. Or it could be an immediate patient that needs it right now. I mean, they go through all the different elements of these cases to see who's worthy of it. It's really kind of hard. It's kind of like the Hunger Games of who gets to get the platelets. So oftentimes platelets are, if you're able to donate platelets, my sister goes twice a month and donates platelets, because my younger sister not alive anymore, but she did get to have a lot of platelets when she was in treatment. And my sister just says, I'm just paying it forward to keep somebody else alive. I can't give any kind of blood products, but a couple of my siblings do for that reason. It says ED nursing notes, 2300 admitted to the ED, brought by a friend, said he doesn't feel well. 2345 initiated IV access. They should have done that at 2300. Pulled blood samples and gave a normal saline bolus at 2430. H&H came back super low, 6.2 and 18.7. Ordered 3 units of packed red blood cells from the pharmacy. Well, they're from the blood bank, but not the pharmacy. If you are the RN, what are your next steps? So in talking about the steps of a blood administration, we go through each one. What are our next steps? So when they did the H&H, they did a type and cross match, I'm sure. And we're going to confirm a blood transfusion order. Before the blood arrives, we have the patient sign the consents that you're getting blood. Because again, that young man may have not been feeling well, but he could have also said, I'm sorry, I don't accept blood products. And they have to go to plan B or figure out what they're going to do with this guy. Obtain pre-blood arrival vitals. So you're going to find out a baseline for this patient. And then here's where we start. We've got our consent signed. we know that the patient's getting blood, and I give you a different scenario, not an ER scenario. I'll give you, excuse me, a Med-Surg scenario, but we prime the tubing. It's a Y-shaped tubing. We prime it with normal saline. Blood can only be given with normal saline. That's something that you'll know across the board. You never give blood with anything but normal saline. And then we clamp it and get that ready. When ask someone to do blood checks with you, yes, when the blood arrives, you have 30 minutes to get that blood hung up and started. So you take the blood bag. Before you even take it to the room, you do a bag to tag check. Bag to tag check, make sure that the tag matches the blood label. You go back and forth, another person checks it with you. It says obtain baseline vital signs. You and your RN friend check blood with the lab slip, which is the tag on the bag. It says state name, expiration date, patient's ID, blood bank number, blood component, donor number, expiration date, and the group and RH factor. Double check normal saline slide clamp. Okay, we're going to stop right there. This is just the initiation. I'll go through each step with you one more time in the lab, but the bag to tag check, then you go in to the bedside. You're going to take another set of vital signs. When you open the MAR, you're going to do a lot of scanning, and what the screen that you're going to populate has 3 different barcodes. It's a really excellent system. We can curse the Epic system as much as we want, but the one thing that they did get right was the blood flow sheet. So you get to that flow sheet and it tells you exactly what to do. It tells you every single step that needs to be taken. So as far as, you know, between B and C, as a student, we have a lot of different things that we have to do. So we checked everything. We did the blood vital signs. We did all of that. And before we spike that bag, we check it one more time. The nurse and another nurse will be in there with you. They'll check it. Then once that bag is spiked and the saline on one clamp is closed, you can open the blood clamp and it will start to prime the tubing with blood. Now, blood always starts at 75 a minute, but the problem with that is we started at 75, but if you start the saline going through at 75, it takes forever. So I have to actually show you what I'm talking about. So we're going to go through and get the blood right to the patient, right to the entry of the patient. Then we stop the pump. So you can do that very quickly because it's 23 cc's of blood, of saline that's going to the patient quickly. It's not a big bolus. It's not a lot, but you stop it. And that's when you would start your transfusion, right when the blood reaches the patient. Okay. Then you would start it at 75 and for 15 minutes. And at the end of 15 minutes, you will, with no adverse effects, at the end of 15 minutes, you do vital signs again, and you increase the blood pump to the ordered dose, to what the order is, what says how fast you're going to be giving it. But you do a second set of vital signs at that time. And you see, this is what the barcode looks like. I usually do this in the classroom with the tubing right here, so you can kind of see what I'm talking about. But we're going to do that again. We're going to do this all over one more time again, so that you can see it. You can go through the motions and you're able to set up your blood pump and walk yourself through it. It says one RN will be reading aloud the blood bank orders while the second RN will be comparing silently to the blood bank. The second RN will hang the blood bank, which could be the student, to the first RN and now read it aloud from the EMAR. And while the first RN compares silently, 2 checks prevent a mistake. Now, the biggest way to alleviate blood transfusion reactions is to go through all these steps to make sure that no checks are being missed, so that all the safeguards are in place. That doesn't mean to say that there won't be a blood transfusion reaction. We talk about when we're done, we go through, you're checking the patient every 15 minutes constantly, not vital signs, but you're checking on your patient, see how they're doing, no reactions. It goes through in an hour or so, and maybe 2, sometimes depending on the fragility of the patient or the necessity of the transfusion. But We flush the site with normal saline. We take another set of vital signs. We dispose of that tubing and bag in the red bag and the dirty utility. We document. Now for the start, transfusion start time and stop time, the flow sheet makes you document it. It makes you document the start time. You cannot walk away from a patient unless you do the stop time, because the Epic will keep putting up a yellow screen. Is this patient still getting transfused? Somebody went home to San Ynez without doing that, had to come back and actually stop the transfusion because it was not stopped in the flow sheet. So in the mind of that screen on that patient, it said that this patient was still getting transfused. She was furious that she had to come back. It's a new system, but it's an excellent system, and we'll go through that. You're following all the protocol. We'll go through again with the fine-tooth comb, and I'll give you everything that needs to be done. And then you write an SBAR, and you know the documentation is key. You come back in 15 minutes, 20 minutes, and you check on your patient. And that is, you know, pretty much what we do. There could be several types of reaction. It could be fever, dyspnea, hypotension, urticaria, anaphylaxis, hemolysis after transfer, all of these things. And sometimes there will be a medication order for a pre-medication, meaning that they get Lasix so that there's no fluid overload. They get a Benadryl, an IV Benadryl that will help them. It is an antihistamine. It's the histamine blocker so that they don't feel any of that anxiousness or any of those, you know, different types of symptoms that are not, they might be a little symptom, but they might not be something that hinders the transfusion. So here it says fever, bacterial sepsis, contamination, acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, and transfusion-related acute lung injury. There could be an acute lung injury, circulatory overload, dyspnea, anaphylaxis, acute hemolytic transfusion reaction, or a bacterial sepsis. And then hypotension could bradykinin mediated. Oh, students are calling me. Nope. Let's see, bacterial contamination, acute hemolytic transfusion, anaphylactic shock, a bradykinin mediated hypotension, anaphylaxis or a minor allergic reaction. And in that case, we have a whole different system that happens. If any acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction that could happen like a day or two after. It's really a weird thing. And we do talk about it we watched the slide, the day in lab that the hospital gave us. And that's something that if you work at Cottage, you will go into your orientation and they will go over that exact one because we took it from them. So an acute hemolytic reaction is immediate, a febrile 30 minutes to 6 hours after, a mild allergy up to 24 hours, or an anaphylactic could be immediate. And here are some of the symptoms. So for anaphylactic, you're maintaining airway symptoms, could be wheezing, dyspnea, chest tightness, cyanosis, hypotension. We give O2, IV fluids. You know, obviously we stop the transfusion immediately and we give IV fluids of normal saline. We give some antihistamines and some corticosteroids. But in an acute hemolytic would be immediate, mild, or life-threatening. Now, when we say that, you could get a patient, you started the transfusion, all of a sudden they're getting super anxious, they're getting super panicky. It could be a psychosocial thing. It could be something that you can really assist with it and talk them off that ledge. And it could just be like, you're still going to call the physician, you're still going to stop the transfusion. You may have to pre-medicate again because it could be all, you know, like an anxiety-driven reaction. I hope that makes sense, like something that's caused them to freak out. And there's ways when we set up the transfusion that I can show you that are really safeguards in that respect. So what I'm saying is what can happen with that is they get kind of anxious. So we go in as the student and the instructor and we set up the tubing. We take vital signs. We talk to them about it and we set up their pump behind them. we're talking to them and we're setting it up at 10 cc's an hour. It's going like a tiny little drip just to keep open. And in that case, you're going over it very slowly. You're talking to them. They're already getting an infusion. So they're used to the fact you're not just going to walk in with blood, get it started, get them hooked up and all that. They're already kind of getting the idea. And you're talking to them, you're educating them, you're letting them know that, you know, you are very low. You are going to start feeling a world better once you get this treatment. Once you feel the transfusion completed, you're going to start to feel a lot better. Hopefully, you know, we get this done and you do feel the effects right away. You start talking them through it. And a lot of times this talks them off the ledge. And having this infusion going at 10 cc's an hour is not, you know, it's just to keep the line open, but it's also getting them used to the fact that they're already getting infused, it's going in. And then when you come in and you do your thing, you try to do it with the least commotion as possible. And as it starts to infuse, you know, sometimes I'll just cover them with the blanket, let them distract, and I'll sit with them, talk to them. You have to stay in there for 15 minutes, which for you students and the instructor, it seems like 15 years. It seems like you are in there forever. At that point, you have a discussion with them. You talk, you know, just start talking to them. You're cleaning up the room. You're tidying up their bed. You're just being present in one aspect, but not in another. You're trying to just make this a smooth transition for the transfusion to go through. It is, we talk about all these things when we watch that slide, we watch it in lab, we go over it. I show you the whole setup. You and your lab partner will get a setup and you'll go through all the steps. And actually it's a doubled up because there's more than one, because we don't have that many arms, but everybody has to go through the process. Each person has to get signed off on it. So we go through all of that. And in the scenario in the lab, it'll be 4 students, sometimes 5 if we have an odd number. And it'll be one person will be the administrating nurse, another one will be the patient, another one will be the clinical instructor, and the other one will be critiquing it. And you guys will all switch roles. You'll do it 4 times. By the time you've done it the 4th time, you've got it down. Because one person might forget something, you'll be, oh, what about that? You'll be that person that'll be dinging the person and saying, no, start over, go through all the steps. Because once you go through those steps and you remember those steps, when it comes up for that question to be tested on, you will definitely know the answer. Now, TPN is another thing that I know you've seen in the hospital setting. It's usually given by 6 o'clock at night. We start at 5 to 5:15 to give the TPN. It is for the patient. It says TPN is a combination of carbs, lipids, proteins, electrolytes, and trace elements. It's given to a patient who is not absorbing nutrients, who maybe doesn't have a stomach working, their gut doesn't work, or they've had a gastrectomy. They are individualized by the team of physicians that are taking care of these patients and the pharmacy. They make this bag once a day. It says a TPN bag may contain IV drugs like Tagamet, heparin, and insulin. It says specialization is the reason to verify contents on the EMR. So what happens first is you get that big bag of milk, you take it to the breezeway with another student, you open the MAR and you read off each thing that's ordered and make sure that it's on the bag. It's a bag, the bag to EMR check, and that's done. So you come to me and you say, I have to give TPN at 5 o'clock. Me and my classmate, we checked everything, everything's right on it. Because oftentimes what will happen if it's not right and they're lacking something, they have to take the bag back to the specialist pharmacy lab and add it. But if it's got something that's too much of something or something that's in it, but not on the orders, they'll make since they can't take that element out, they'll make a little adjustment to the order because these bags are several $1,000s a piece and they're not going to throw it away. I have one in the lab that I'm so proud to show you because it was discontinued and I snagged it right up from that hospital because they were going to throw it away. And I was like, no, I want that. So hopefully it's not rotten yet. I haven't looked at it this semester. I've already had it 2 semesters and there were 2 and I almost got 2, but the second one did get me. So It's very seldom. I've been there a long time and we don't get those. So for a while, you see how this has got the lipids here and the other elements here. And they kind of met in the middle, and for a while, we weren't able to get the full bag mixture, so they were doing that, but we're back to getting our TPN mixed. So it is a really, it's a very interesting process, and I'm going to show you how to do it. I'm going to show you how to do it in lab. I want you to go over it with me once, because there are several steps, and I'm not in clinical with you guys this semester, so I'm kind of bummed that I can't show you the way we do it, but we have knowing the difference. We have PPN and TPN. PPN is 10% glucose, must be less than 900 of osmolarity. It must be connected through a peripheral vein and usually requires increased fluid allowance. TPN is 10 to 25% glucose, no osmolarity limitations, and must be in a central line. So for a peripheral and doing the PPN is not as involved and intense as it is. You're still hanging the medications. The thing I want to let all of you know is that you are this isn't new to you in the aspect of the fact that you are giving a large bag of fluid, okay? If you think of it in that way, it's like a primary bag. It's just gigantic. It's a big fat bag. But the fact that you're giving it is, you have to understand why you're giving it. So if anybody has does anybody know why you would be giving this and what kind of stipulations there are? The only reason I'm saying this is because we did have a traveler that came from another hospital, and parenteral nutrition was given, an NG nutrition was given into the peripheral IV, and it killed the patient. So that was something that was very scary. And the the total parenteral nutrition that can only be given into a central line was given nasogastrically. That didn't hurt the patient. It was of no use to them, but it did kill a patient when the wrong connection was given and a tube feeding was given peripherally. Does that make sense? It's kind of confusing. Okay, so you have a tube feeding that can go into the nasogastric feeding right into the stomach. This is the total peripheral nutrition that's given only in a central line, and then the PPN is parenteral. It can go into a peripheral line. That was such a mistake and such an error, and I'm sure that the nurse that was traveling here lost their license, and of course there was no intention there. They were just not educated in it. So it does require respect. This is something that needs to be verified. It takes 2 nurses to check it. And when we go into the patient's room with hemostats, with cap changes, with flushes, with our new bag of TPN and new tubing. Every time it gets new tubing. And I always take 2 students with me because it's a great learning experience. Wait a second, Brian. It's a great learning experience to have the 2 students with you, and it's bulky. So you're going to go in, and we go in about 5:30, 5:45. We stop the old TPN, or if it's not connected, we start there. Now, let me see. Yes. What's up, Bear?
Yeah, you said total
Parenteral nutrition.
okay, because you said total peripheral nutrition. I just want to make sure.
Okay, no, PPN. That's
Partial. Peripheral.
yes. Okay, so but listen, so when you go into the patient's room, there's 2 students and maybe your clinical instructor. Once you get all that set up, now let me give you 2 different scenarios. One scenario could be it's disconnected because they're cycling. They only get it at night. Okay, so they're not connected. But every single time you give TPN, you do a cap change at that point. Friday, we're going to go over the cap change, but you do a cap change. So you're going to go in and make sure you have your med trays. You're going to go in with cap changes that have been primed. You're going to go in with extra flushes. You're going to go in with your TPN. You're going to have hemostats, because let me tell you why. I'm a big moose and I cannot open those. My hands are weak. I'm strong, but I'm weak, okay? Hemostats, every nursing student has them in their pocket. If you don't, terrible. But I never have met a student that doesn't come with all their equipment. We go in and sometimes we need two. So you hold on to the site and to the cap and you undo it. Okay. When I do that, I'm going to show you. You put a towel underneath that. You go in and you scrub that junction first. You open up that cap. You remove the cap. You scrub that area again with your alcohol. You put the new cap on and then you flush 1, 2, 3. Okay. That flush is connected to that clean cap. You can leave it just like that. You can just set it right down there on that towel and you can have all your, you can prime your tube. You can put your tubing through the pump. You can get it all ready. At that point, sometimes there'll be the tail like this of that tubing and it has a big block of air in it. Open the line and get that air out. Let a little bit run through. You have your garbage can right there and you stop the pump and you connect it. The primary nurse will come in and let me guarantee this to you. The primary nurse is thrilled when there's semester 3 students on Med-Surg to do all the TPN. They're wrapping up their charting, they're getting stuff done. They have to stop at 5:36 and go hang TPN, and it takes a minute. They would much rather have students do it, and we get practice every semester doing it. So I will have Josh did it last week. Josh, go with Sean and you guys check the TPN and you go through the steps with them. Then those two will do it. Then the next week I'll have Sean do it with Javier. Javier, you go in with Sean. Sean did it last week. By the end of the semester, my 6 students have done it 10 times. And it's really a good practice to get into because there are a lot of steps. So make sure that you know why you're giving it, what you're giving. It says confirm, verify IV access. You definitely have to have your central line working before spiking it. You want to make sure that you're not going to spike it. You're not going to do anything. You prime it in the bedroom. We do all our priming in the bedroom. There is one valve sometimes that has to come off, that tubing. You get the tubing that doesn't have any of the ports on it because nothing can get put into TPN. It said, and you put a filter on the end of that tubing. I'll show you all of that in lab. You enter the room just as if you were entering with any kind of medication. You enter the room, you check the patient, you make sure that you've opened your MAR, you've scanned it, you scanned everything, you know what you're doing. It says clamp the central line. They're non-valve generally, so you're not going to clamp anything, but I'll show you both types. And you clean the port with the alcohol for a full minute. You scrub it because it's been in their bed. It's been all, it's got all kind of funk all over it. You want to do a good little scrubbing of the junction before you open it. As soon as you release that and open it, you scrub it again before you put the new cap on. Apply the new tubing to the port. You connect the pump. TPN must be on a pump always. You program the pump. It says, do not decrease or slow down TPN levels because blood glucose levels will fluctuate. We can talk about that right now. Unclamp and you start the infusion. Nurses will try to do this 75, piggyback this and that. When you're doing it, you do it exactly to the order. If they want to come in behind you and do what they want because you have to check it after an hour, they can do that, but we do it exactly accordingly. Okay. TPN could be going 24 hours. Those patients get blood glucose checks 3 times a day and at bedtime, even though they're not eating anything because of the glucose that's in the solution. And then the ideal thing is for the gut to start working. So they'll channel it at night. So they'll put it in at 6 at night and end it at 6 in the morning. And during the day, the treatment plan would be to introduce soft foods, solids, liquids, so that to see if the stomach tolerates it.
You're still going to be doing your blood glucose checks and you're wondering, well, why am I doing that if the patient's not eating? It's because of the continuous glucose. If for some reason the TPN gets stopped, they could have a hypoglycemic episode and they may need to get a bolus of D50. It depends on what's ordered. They may need to get a bolus. So that can always be close by. Make sure that you are aware that TPN has been stopped, that type of thing. So there's that factor to consider. You, of course, are going to monitor the blood glucose. Go through these later in lab as well. You're going to want to monitor the blood glucose levels. In talking about TPN, we talk about the cycling patients, we talk about the 24-hour patients that are getting it continuous. We talk about patients that go home with it. So we'll go over all of that in the lab. Some patients go home with TPN and some patients have to live on TPN for the rest of their life. That's part of their, their treatment plan. But oftentimes once the body's healed and they get weaned off of it, they will do that 6 to 6 cycling, introduce foods, and then sometimes it can get discontinued altogether. And that's what happened when I grabbed that bag of TPN. It was super exciting. I have the filter to show you, I have the tubing to show you. You can go through that, and that's more of a discussion. As far as a skill, you'll really be doing the cap change and then hooking it up. You have to really put your hands on an actual primed bag, which I will show you how that works. You have to actually put your hands on it in the clinical setting to understand its flow and how it works. It is always good to have a partner in clinical, so better to have friends than enemies, work together. That's an important thing. Anybody have any questions on the actual TPN? I saw somebody's hand up earlier. So really, okay. The blood in TPN is another skill that we do after our insulin. We'll go through all that. You can start studying it, looking at it, maybe writing up your bullet points. And that's pretty much the skill there. And we have, let me see. Go. Let's see if this is our transfusion list. Yes. Okay. Well, we really don't have that much time to go over it, but this, if you want to take a look at it later, it's a lot of slides. And don't forget to, when you look at this is for all areas in nursing, not just nurses. So it just tells you exactly what's done, the IDs, the specimens that the lab people pull up, because when we're in orientation for the hospital, it's not just nurses, it's all different areas. They'll even, they talk about all the different things, and it gives you all the compatibilities, how to ID the patient, all of that. But the thing with our purpose would be the fact that we have the bedside actual transfusion ability to give the transfusion. We have to be up on all the different things that could happen, all the different side effects, what happens in the case of an actual reaction. And that's a whole nother big flow sheet that has to get filled out. Quality assurance comes. It's nobody's in trouble for anything like that, but they do go and they take the blood back to the blood bank, and several tests get run on that blood. And if you see like a bag of blood that's infusing and it has like the little kidney shaped tubing with little bits of blood, each one of those is used to be tested if there is an actual reaction, a true reaction. Like I said, some people will go through and, oh, I'm feeling this, I'm feeling that, and you can talk them down, you can medicate them, and the physicians will say, keep the transfusion going. Otherwise, they'll say, take it away. We're not getting that. I mean, they need a larger gauge. IV started the larger gauge, sometimes it would be like maybe an 18 gauge, because the blood is a little bit thicker than something else that could be administered, I guess. We go through the stuff that we're responsible for, like priming and getting the order and getting the consent and all that. We go through all of those and all the steps to prepare things. So, and here's the prepare the order and get that sent to blood bank thing. We'll go through all of these things in lab. And it's a 2-day lab. We go through this, we get the practice, and then you get ready to get signed off. So this is just something to look at. This shows you here the flow sheet that gets populated as soon as there's an order written and the orders have been released. In your flow sheets, you'll see the blood administration flow sheet, and it really does help you to understand the entire process. If you're giving 2 units, it will not let you get the second unit until you've stopped the first unit. So it's a really interesting process, and it's helped immensely It's helped immensely with any mistakes that could happen, and documentation omissions and all that, because it doesn't let you slide. It makes you, and you go through each thing. It tells you what's the blood pressure, what's this, what's that, what's this, what's that, and you don't really have the option to not do it because it doesn't let you go to the next screen. So once that's filled out, you can release the second unit. For blood tubing, you can only have 2 units per tubing. So if you have 2 units that you're transfusing and you're going to be transfusing a 3rd unit, you have to set up another tubing. You have to set up another set of tubing for that. And that's what it looks like. And we have pretty good fake ones in the lab. And we have the cross match and the uncrossed match for emergencies. Our lab's done a pretty good job. One semester, a couple of semesters back, the lab bought this red mixture stuff that we were supposed to mix up and make this big mess. I'm not into messes. I was like, send this back. I don't want that. I don't let you guys prime the tubing with our fake blood because it's a big mess and it's a disaster. And about 4 semesters back, after I said it so clear, one student was like priming the blood everywhere. We're like, everyone's like, what are you doing? You're like, we stopped her and she was just like, I'm getting it ready. I was like, you clearly didn't listen to what we said in lab, but okay. We're going to call this was a mistake, an accident, don't do it again. But we went through that. We don't prime the tubing actually, and we don't spike it, but we tape it up there so you can see the whole setup, and we pretend. We do a lot of pretending. So you know how that works in the lab. Records, vitals, EMR, all blood products must be transfused through our filter. We have the Y setup. The emergency, I've seen the emergency setup done in the ER to one of my clients that fell and hit her head, and it was scary. It was quite scary, I have to say, to watch that blood get infused. Like in 4 minutes, 3 units got infused in that lady. And she lived, she's still alive. It was over 1.5 years ago. So it was pretty scary. I mean, she was hit her head and there was an artery that was just squirting blood out of her head. It was like a crime scene. It was awful. But they do a lot in Trauma 1 Bay at the hospital. So if any of you ever get the chance, oh, you will next semester. So yep, there's that. We're going to go into our Peds section. I got to look at I have to look and see what we're talking about today. I know I looked at it yesterday. Let's take a look. I think because everybody's already here and you already had a few breaks, we don't have to switch up and go to the other Zoom room. But today, what are we doing? Oh, GI and GU, that's a nice one. That's not a bad one at all. All right, we can do that. GU and GI, I see a lot of people that turned in their growth and development. I thank you all for that. I haven't looked at those yet, but I've looked at all your weeklies, and I do appreciate that you got them in as fast as you could. That's good. That helps. Janie is feeling better. She wants to schedule her growth and development, and I'm going to make sure that we get her in before you guys get to clinical. How many more weeks do I have? 2 more weeks or 3? Anybody know when you're scheduled for clinical? Can you see my gastrointestinal on the board, guys? Does anybody go to clinical in the next few weeks for Peds?
think Peds
We have
starts in
time. I
March.
told Janie, don't worry, but she hasn't been feeling well. She's pretty fragile, but she's great. Janie Wood Clysons. She's a Wood Clyson, so we're nice. She's a nice gal. So the gastrointestinal patients, again, we talked about growth and development, we talked about all those stages. And when the faculty talked about getting a lab for GI, and this was just at our last faculty meeting, the Peds nurse said, I will come to their lab, probably not in the next couple of weeks, and just do a surprise visit in one of our labs just before you guys get to clinical, so she can say to you what exactly to be expecting when you get to clinical. And it's not as in-depth or intense like you will for maternal newborn, because all of that is new. Again, I'll state this, you are taking care of Med-Surg patients. They're just younger. They're just younger with different, the different aspects of care. And as you went through your growth and development module and looked at each section, you do know, and if you've been around little kids, you know kind of where they are and what they're up to at a certain time. And that's important when you're planning their care. There is not that much reading involved, but you do have to know this. I don't know why that. Wait. I'm going to just move something. Sorry, guys. There, that's better. Gastrointestinal topics. And one thing, again, like when you're taking care of the smaller population or the elder population, you have a very fine line before you have a problem. Okay. So GI topics would be dehydration, the fluid and electrolyte imbalances, the diabetic patients, little kids with diarrhea or constipation, the Hirschsprung's disease, acute appendicitis, cleft lip and palate, the pyloric stenosis, intussusception, celiac disease, and pinworms. These all affect the GI area of the patient, and really a big important one to understand is the body percentage. So infants are 75 to 80% water, and children 64% water. So really it is a higher percentage of water in infants, and if there is an interruption or an assault to that system, they can get really sick really fast, and it could be life-threatening. Infants and toddlers are more vulnerable to fluid and electrolyte disturbances, meaning that these little infants or little toddlers, let's say a little infant gets a GI bug, or a toddler is out playing and gets a GI bug and starts with diarrhea, they can get dehydrated and have like a cardiac arrest, a respiratory arrest. They could, the metabolic rate is 2 to 3 times higher than an adult. So, and it says greater body surface area per kilogram of body weight than adults. And they dehydrate very quickly. So it is kind of a scary thing, but it's also a delicate thing, because if you think of a small child, and this is one reason why you have that syringe pump, an infant or a very small child can't just get bolused and blasted with fluid. You could kill them that way too. They could have a brain hemorrhage. They could have, a fluid overload that could really cause a respiratory or cardiac arrest. So it is a fine line. They can lose it quickly, but they need to get it back at a rate that keeps them, sustains life. It's most common would be isotonic electrolyte and water loss. Greatest threat is hypovolemic shock. So if they don't have enough fluid, they could go into hypovolemic shock. A hypotonic is an electrolyte deficit that exceeds water deficit. The threat is water moves into the cell, causing an edema. Hypertonic, accelerated, hypotonic, decelerated. Water deficit that exceeds electronic deficit. Threat is the water pulled from the cell, causing cellular dehydration. So in all kids on Peds, important to determine an accurate INO, which means that these patients are, no matter what they're there for, they have strict INO. And let's say they're voiding in a little pan. Like I told you, sometimes when they get sick, they get a diaper put back on. Every room has a scale in it, and those diapers are weighed. Every amount of fluid that goes into that room needs to be measured, whether it be a popsicle, a juice, the graduate of water, whatever it is, it needs to be measured as well as the IV fluid. And how to calculate the maintenance fluid requirements. It is important to add the IVs with the fluids, how many cc's are going into that room, how much they're ingesting, and how much is coming out. So you're weighing the diapers. It takes 2 seconds. You'll learn how to use the scale. You clear it, you drop it on there, it tells you, and you do the math that way. And you'll do it first with your primary nurse. You can also do it with your instructor. Watch that. Watch our Southern Belle. But when you're assessing these kids, and again, kids aren't easy. Anybody who's got kids out there knows, or babysat kids or knows kids, kids are not easy little creatures, but skin is gray or cold, mottled, poor to fair, dry or clammy, delayed capillary refill, if you can grab it, you know, if you can check that. Mucous membranes, their little lips are dry, their little tongue is dry. The eyes and fontanelle, the fontanelle or the eyes are sunken. There's no tears present when they're crying. You know, when a kid's crying and screaming, there's snot and tears and everything. If it's just a desperate cry and you see that there are no tears present when they're crying, the pulse and the respirations are very rapid and they're a little bit tachypnic. Irritability and lethargy, depending on the cause or severity, not responsive to parents and or environment. You know, if they're kind of listless, you can guarantee they may be, you know, dehydrated. No water, no salt, or both. So it says here, vomiting and diarrhea, the loss of fluid and electrolytes. The diabetes insipidus, where they're constantly having fluid loss or constantly urinating. You're going to watch for skin turgor, hypovolemia, tachycardia, very weak pulse, postural hypotension. So if they kind of are sitting up and their pressures are dropping, they're confused. Dehydration can cause a sodium or water loss. Also, thirst, dry skin, sticky or dry mucous membranes. Their mouth is dry and, you know, cracked tongue, weight loss, very concentrated urine, dark colored urine, except with diabetes insipidus, they just keep on going. Low sodium diet or no sodium intake. So that's an electrolyte deprivation. And yikes, I'm out of salt and water. So they're, you know, like, again, inadequate fluid intake. They're not doing both. It's just like a double-edged sword. So assessing these kids with dehydration, you're definitely want to be super vigilant, and you want to explain to the parent or the caregiver, look, we have to make sure we know everything that's going in. We want to make sure that we do our strict INO. Assess our hydration status. We're going to be looking at, you know, the blanching of the toes and toenails and fingernails. We want to see if there is, you know, when you lift, you do the tenting and there's no, you know, it's not springing right back. It's very suspicious. You want to check their neurostatus, electrolyte balances, and rehydrate with both fluids, PO and IV. If they don't have an IV started, chances are they're going to get one started. And then the progression, especially for a diarrhea patient or a vomiting patient, you will give the antiemetic first and then see if maybe they can take the Pedialyte and hold it down. And then you're going to do DAT or diet as tolerated as you progress. Skin care for diaper rash. You want to make sure that you check that bottom, and it may be red and raw and cracked. You want to make sure that you put the emollient on. They usually have something that's called butt paste, or you can do the A&D or the Vaseline, whatever they're using at the bedside should be properly placed after each diaper change. You're going to check for stool output, and for both you and the safety of the patient, you're going to do very, very good hand washing, because the priority is fluid replacement and then signs and symptoms of shock. You want to make sure that we haven't gotten to that point. So these are really, and they seem like to everybody here listening, like really minor, like obvious things, but sometimes it's not as obvious, and it really does. It really can make a difference, life and death. I mean, often the specific etiology of diarrhea is unknown. It could be the rotavirus. Is the most common cause of gastroenteritis in infants and kids. But the thing with that is kids play in dirt, kids play in sand. Kids eat their own poop. They have poop on their hands. They put, you know, they can get a bug faster than anything. Guess what? They can bring those bugs home to their entire family. So please safeguard yourself with contact precautions. And again, what happens when you're in clinical, like all morning, all hot and heavy, bathing your patient, taking care of your patient, doing all this stuff. And then you come back from your break and there's a isolation card. Oh yeah, positive for C. diff. They're like, oh, gross. I've been in there all day. If you kept yourself safe, if you did what you were supposed to contact-wise, you're fine. Still doesn't mean it's not gross. It is gross. And I've seen, you know, people walk into rooms with patients that have, not so much since pandemic, but before that, patients that are on contact for C. diff, go in with a baby and set it right on grandpa's lap. And this, and I was like, what are you doing? That baby could get so sick. You know, maybe this person is an adult and can fight it off, but maybe that baby can't. So there's just a lot. You don't forget contact precautions. It says leading cause of illness in younger children younger than 5 is definitely diarrhea. It may result in fatality if not treated right. History is very important. Has the kid been out of the country? Has the kid been around other sick kids? Has the kid been playing in sand or dirt? Treatment is aimed on correcting the imbalance for sure and the underlying cause. So diarrhea, remember metabolic acidosis. Remember acidosis with diarrhea, there's D's in it. The brat diet, we give bananas, rice, applesauce, and toast. And we try to hopefully, you know, stop that diarrhea and slow it down and coat the stomach with the applesauce, with the pectin in the applesauce and the rice, stopping them up. Vomiting, alkalosis, diarrhea, acidosis. Just remember those two, they're important. So vomiting, metabolic alkalosis. So often resulting in infection, improper feeding techniques, a GI blockage or a stenosis like the pyloric stenosis, emotional factors. Some kids like to cry so hard they try to make themselves barf. And that is rough. Management treatment towards detection, treatment, and cause and prevention of the complications. So causing of vomiting, it says vagal reflex, vestibular or vagal reflex, opiates, migraines, infections, toxicity, increased ICP or intracranial pressure, ingestion of alcohol, a neurogenic or a GI gestation. It just depends what I feel like for little kids, a lot of times vomiting could be a 24-hour bug, but can lead to much more difficult problems. So keeping them hydrated, keeping food down is something that, you know, oftentimes they'll have to have a suppository, an antiemetic that's in a suppository form because you can't get anything down them. Keeping them still, keeping them hydrated. And oftentimes it has to happen in an urgent care in a hospital because it has to sometimes be IV fluids, because you trying to do it at home can definitely cause, you know, this patient or this person to have, you know, to go quickly. And like I said, there's a very fine line. So you want to be very vigilant on little kids. Remember strict INO. And when I get reported in peds, I always hear strict INO. They're on INO. Endocrine patients or diabetic patients, if they have any kind of GI upset, it can definitely throw the blood sugars off. Hyperglycemia causes insufficient insulin, increased food or alcohol intake. Hypo, it's just like we studied for an adult. Excessive exercise, insufficient food intake, and too much medication or insulin or oral meds. And the onset for the hyper could be gradual but very sudden for a hypoglycemic patient. And I do know, I don't know if it's on this test or the other test. You got to remember diabetes is universal for both classes. You want to make sure that they're checking in exercise, checking before, during, and after exercise, and that they are eating and not doing their exercise at the same time every day. So for the hyperglycemic patient, thirst, hunger, fatigue, confusion, blurred vision, hypo, fatigue, nervousness, anxiety, headache, body ache, tachycardia, hunger, shaking and cold sweats, and then the visual changes. Those go for both. And what can happen if it's severe for both of them? Seizure, coma, nausea, emesis, seizure, confusion, and hallucinations. So, I mean, the treatment, of course, test the blood sugar, give insulin and fluids if needed. For a hyper, oral or intravenous and normal saline. And for the hypo, test the blood sugar. If the patient can take orally, give orange juice or hard candy, recheck the blood sugar in 15 minutes. For adult, 50% dextrose IV, and that's also when you stop a TPN. For a child, 25%, infant, 10%, and recheck blood glucose in 15 minutes. For a newborn, it's a gel. It's a glucose gel that they give the baby so that they can absorb it fast but slow. Hard to explain that, but it doesn't just go in and hit them. They can absorb it, and the gel gets repeated, and Mary goes over that with you. If it doesn't correctly sell for the infants, they definitely go to the NICU, and then they get put on an insulin, IV insulin, whatnot. It's kind of a rough thing for the new parents. Sick day guidelines. This is always take your long-acting insulin and have a basal pump running. Sick day guidelines for vomiting, diarrhea, fever, or anytime a child is homesick. Check ketones if blood glucose is normal. So anytime a diabetic kid, diabetes insipidus, type 1 or type 2 diabetic, for these kids, it says blood glucose is within target range or higher and ketones are negative, continue the blood glucose check and ketones every 3 hours, especially when they're vomiting with diarrhea. And then here, if blood glucose is below 150 and urine ketones are moderate to large or blood ketones are above 1.5, bring blood sugar up first. So you give the fluids, the glucose tablets, you can give the bolus of, it says Gatorade or Sprite, a sugary drink, and then you're going to still keep checking them every 3 hours. And this is just a guideline for kids. It's a little bit different for adults, but for kids, there again is a fine line. And we do have this sick day guideline for our diabetic children. Hirschsprung's disease is an interesting one, an aganglionic megacolon. So you see here the normal proximal colon and then a dilated colon, and there's pictures of it. And a no ganglion cell at affected area, usually at the rectum or proximal portion of the lower intestine. It's the absence of the peristalsis, so it doesn't have that pulsing sensation. It doesn't work. And that leads to just the stool sitting in the lard, sitting there in that dilated colon, and ischemia, and it may be enterocolitis. Treatment is mild to moderate. They use stool softeners to get the stool passed. They use a rectal irrigation, which is a tube with some warm fluid, soapy water sometimes, and to clean out the rectum. Moderate to severe is a single or two-step surgery where that area that is not got the ganglion cells will get eliminated, and an anastomosis happens, and so they'll have a shorter colon, or they have to have a colostomy. Hirschsprung's is something that is, you see normal and you see a swollen colon. It's something that these kids suffer with, and it can be corrected, but they kind of do have a tough life because they have, problems with malabsorption. Signs and symptoms in the infant, they're unable to pass the meconium stool within 24 hours of life, and you can't go home from the hospital. Newborn has to pass stool. Now, as a newborn nursery nurse, it's been known to do a little digital stimulation of the colorectal, the opening, and give a little lubricant with a thermometer probe, because we always used to check rectal temps. We don't do so much anymore, but doing that little bit of stimulation can also cause that baby that might be a little tired, sleepy, or listless to poop, and they don't have a blockage. But abdominal distension, a bilious vomiting, meaning if they have bile, they're throwing up bile, they could have a blockage. Their refusal to feed or their failure to thrive, meaning they're listless, they're sleepy, they don't have that drive that a newborn infant would generally have. For a child, it could be just chronic constipation, pellet or ribbon-like stools, and they smell very bad because they haven't done the proper absorption. And then a lot of vomiting and failure to thrive, or FTT. For those infant and children's signs and symptoms, the intervention would be bowel cleansing. So they're going to do the Go Lightly. Sometimes they'll put it in like a Crystal Light or a fruit punch or something, so it doesn't taste so bad, because the Go Lightly can be kind of salty and hard to get down a kid. kids like blue drinks. They put them in those gross Gatorade blue drinks and drink it down, and it cleans out the stomach. Antibiotics, then nothing by mouth. After they do the bowel cleansing, they can do fleets enemas, soap suds enemas. They do IV fluids, therapeutic play for surgery and preparation. That's where Janie will come in with the little body that has the surgical incision, and then the one with the colostomy, and say, you know, you're going for surgery. These are the things that you might have when you come out. And she talks them through it. It's really quite interesting. Infection of the skin integrity, monitor the ostomy. If there's a stoma on the abdominal area or in the anus, you want to check that. Nutrition and hydration, it would be an NG tube, NPO, then advanced to diet as tolerated. Assess for bowel function, you're listening all the time. And then the abdominal status, whether it's taut, whether it's soft to touch, whether they're passing gas, all of these different things, that would be interventions. I'd have to say this is a tough one for kids to go through, because just thinking about it, anybody out there that has kids knows this is really, that would be a lot for a parent to have to go through. It isn't very common. You don't see it very often. About, I want to say 2 years ago, we did have somebody that had the colon resection and the kid did fine. It was a 3-year-old. For an API, an appendicitis, inflammation and infection of the vermiform appendix. So it's a periumbrial pain, right lower quadrant pain, and then in McBurney's point. So you're looking at, you get right, you go down, lower pain, fever, vomiting, diarrhea, lethargy, irritability, and generally that will be trigger the parents to go to the hospital to have the child assessed. And when they see an increased WBC, they probably do an ultrasound and they say, it looks like we've got a appendicitis. Hopefully it hasn't ruptured. 1 semester, 2 semesters ago, we had our little girl Elvia, and she was in the hospital the whole semester, and somebody took her every week. She was darling. She was 5 months old, and she had a ruptured API. So they had to do washouts, they had to do wound vacs, they had to clean her out, a couple of surgeries. She was great. She was really cute, and she really liked all the students. A surgery is necessary if it's ruptured. They will receive antibiotics prior to and afterwards, depending on the severity. Pre-op care is NPO, pain management, hydration, prep and teaching, and consent. And of course, it's for a child. We're going to want to, if the child is, you know, older than 6 months or a year or two, that they can understand things, you want to show them pictures, but more so to the parents, you want to do the teaching. This is what you can expect. This is what we're going to talk about. Post-op care is routine post-op care. IV fluids, antibiotics, MPO, then MPO, and progression to diet as tolerated, or DAT, ambulation, positioning, pain management. You're going to check the wounds, and if there are drains, you want to make sure that the sites are within normal limits, that they aren't having any crusty, you know, fluid coming from them, any residuals, so that you can, you're checking for any signs of infection, but you want to make sure that there isn't any discharge. That's the word I was looking for, because then that could be a big sign of an infection and a bigger problem. It's rare in children less than 2 years old. It begins as dull, steady pain in the periumbrial area, right side, progresses 4 to 6 hours and localizes to the right lower quadrant. And then the fever, nausea, and not ability to not eat. Sudden pain relief indicates that it could have ruptured. And then all of a sudden you'll get a very elevated temperature. So they need to get into the hospital right away. And when it has ruptured, sometimes they won't open them up right away. They'll put them on antibiotics for a while, then go in, do a washout, remove it, and they will be in the hospital a couple of days. So that's an important thing to remember, the tenderness. And then sometimes it could be they just have, you know, constipation, or they got hit in the side or anything, but you know, it's something that always gets worked up. We have the cleft palate, which would be, they're born with the cleft palate. There'd be an interruption to them being able to be fed. Their nutrition status is altered. It's a challenge in infancy. There is always, you know, there's a multidisciplinary care throughout the childhood and early adulthood. So several surgeries should be expected depending on the severity of if it's just the palate or if it's a lip and palate or if it's both sides. I'll show you a few different ones. Nutrition is a challenge for the parents as a newborn. It's very hard to feed. There's a special bottle with a long nipple that you put at the back of their throat and you kind of squeeze in the pumped breast milk or the formula, whichever, is the choice of the parents, what they're doing. And one thing that is a real important factor to remember is the altered bonding is a possibility. Sometimes the new parents are afraid of these babies. They're afraid. They didn't sign up for this. This is not what they signed up for. Some have a really hard time coming around, and others have that internal maternal paternal instinct where they want to guard their baby. They don't want anybody to see their baby like this. They want to talk right away about surgical procedures. And there are surgical procedures that happen right away. Here are a few different types. This is the upper lip, hard palate, soft palate, and uvula. So, and then here is one where there is one side is altered. Here, here is one side of the lip there is an interruption, both lip and palate, and it shows you the different ways. This one was fixed. This one, it goes, right here, you can see a little bit of a line. And then, several, you can see some of them have, the lips are normal, but the palate has been. This one, bilateral cleft lip plus the palate, the cleft palate, that's going to be a lot more intensive surgery. We had a newborn infant that the pediatrician, the nurse that admitted the patient missed, and a student discovered it. It was tiny, like a tiny little pinhole in the top of the palate where the baby started to breathe and you could see a little tiny hole. And she goes, "What is that?" And we called the pediatrician over and she goes, "Wow, that is a cleft palate. It's very small, but you see at the back of that throat and the F picture, the soft palate only, there was a tiny little hole and it was missed. It wasn't noticed upon admission assessment from a nurse, admission assessment from the pediatrician. So that was like a big find. That student is a pediatric nurse now, and she thought that was a fantastic find, which it really was, because the kid could have gone home and had some aspiration problems and then it would have been discovered. But that was an easy fix. Going back, they do wait, I think, a few weeks, 6 weeks before they do their first surgeries. And the objective in the beginning is not so much cosmetic, but it is more to correct the palate so that the infant doesn't aspirate when they're eating. Those long nipples that are probably, the length of the small bottle, and it has a little tiny nipple that goes to the way back in the throat, and the bottles are just like the softest, almost like baggy form. You push slowly, and they have to be sitting up at a certain angle. I used to feed the cleft palate babies a lot because I had a good system with them. A little bit of a burp, and sometimes when you're all done, you give one little burp and it all comes out through their nose, their mouth, everywhere. So that was kind of a wash, and you'd have to start back, square one, give them another feeding. But in the beginning, it's done a lot by the nurses, but then it is done to, it is also a lot of teaching for the parents and a lot of support and a lot of surgeries, and they're put into a system where they get support from the children's services for, all of the way up until they're 18 years of age. And we actually had one nursing student that had a cleft palate and she explained she has a slight speech impediment, but by looking at her, you couldn't tell. So I really feel like, and she was, in her 20s, they've come a long way with the plastic surgery procedures that they do and how they can fix things and make people, look a lot better. The one thing that's hard to do is the dental aspect of things, because if there is a big disruption, the teeth are generally harder to, baby teeth, and lose those, and then actually years later get the actual implants that would be probably what would be the choice of somebody that has really a big interruption in the palate and not having normal teeth growing in. it's a lot. It is a lot, and it's a lot for the parents. So the parents need a lot of support. Pyloric stenosis causing of the narrowing obstruction of the bands of the pylorus. If it's a brand new baby and you're burping a baby and they can throw up across the room, sometimes you'll know that there's something wrong with that pylorus area. The pyloric muscle right here, you see here, it's hypertrophied and it's kind of closed. So the sphincter it's causing a narrowing or an obstruction. So when the baby eats, the band tightens up and they barf it right up. It usually occurs between 2 to 8 weeks of age. Can go in for a quick laparoscopic surgery where they go in and they kind of ream that area. They open up that area where the muscles hypertrophied, and it causes such a relief because here they feed and in excuse me, adult type flat, they're throwing up. And these poor parents are exhausted. They need a ton of support. Again, it's just a general surgery. It's not something that takes a long time to recover from. They go in and the history of it's like the little physical exam is like an olive palpated in the epigastrium that you can feel in the tummy of the baby, upper GI string sign. They go in, they'll look, they'll see, and generally zero absorption. They're losing weight. Upon abdominal ultrasound, they can see the affected area. They do a pyloromyotomy, hard to say for me. They go in and they actually kind of cut around that sphincter, small little cuts all the way around to open it. And their NPO, NG to low intermittent suction, hydration, INO, monitor for electrolytes. So they do get the IV fluids. Post-op, start feeds in 4 to 6 hours, and they're slow, but the infant is keeping them down and they're passing stools. And you place them on the right side to prevent any aspiration and to promote stomach emptying. The patients that we've done this many times. Almost every semester there is a baby that has pyloric stenosis, and they go in and open this area up right here, and that hypertrophied area, nobody knows exactly why that happens, but they definitely have positive outcomes. I've never seen any one of them come back. Clinically, they have that projectile non-bilious vomiting because it goes into the stomach and comes right back out. It's immediate, like right after they eat, they vomit, and then the infant is hungry in between feedings. So that is really kind of like the telltale sign. On ultrasound, they get ultrasound lab work, and they do the pyloromyotomy. That's right. Really no ill effects to that. It says it's more common in boys. It's a genetic link, strongly maternal. Signs and symptoms, like we said, the weight loss, the vomiting immediately. Hyperplasia, hypertrophy, and circular longitudinal muscle layers in the pylorus, and that is the narrowing, or that here you see the hypertrophied pylorus. And good history and examination. If they're dehydrated, they get rehydrated. They do a test feed, and the kids generally will go home within 2 days. So it isn't a really hard, it's not hard to diagnose, and it's an easy fix. That's what we can tell. This intussusception is a hard fix. I mean, it can be very dramatic. I don't know in this class how many people work in the ER, but when these cuts come into the ER, it is a scene. They are screaming bloody murder. So if you think of your intestine, it kind of gets shoved back, or telescoping of one portion of the intestine into another. It's a very fast onset, happens usually in 3 to 24 months of age, sudden abdominal pain, and then their poop is like a thick red bloody jelly. abdominal distension, they're lethargic, and this can lead to shock. So treatments would be, well, here, this is how you find out if it's a barium or air enema and abdominal ultrasound, but the treatments, they can sometimes use fluid force to do, like they put in a tube and they put in a saline wash, and it forces that part of the intestine that's shoved up to push back down. And air and fluid is a non-surgical intervention. It's painful. The kids have to be sedated, but chances are with that type of a treatment, it happens again. So the surgical reduction is they go to that area. If the surgical reduction, if the hydrostatic doesn't work, they go to that area and they cut out the affected area, reanastomose it. And again, it's like another intestinal surgery. So monitor for signs and symptoms of shock and pain, infection, maintain their hydration, very strict INOs. Where it says it happens to 3 months to 24 months, preparing the child, it's more so preparing the parent for the hydrostatic reduction to teach and consent an MPO, a nasogastric tube. But if it doesn't work, which sometimes it does work, they wouldn't have it. But generally it is monitoring this patient pre and post procedure. Surgery is general, pre and post-op care like any other abdominal surgery, but it's a lot of teaching for the parents. It's a lot of support for the parents. And it's something that is, it's really scary for them because you see this intestine got shoved all the way up. They tried to do like a blow bag and blow it all the way back out and sedate the infant and hope that it doesn't creep back up there. But again, what happens is generally they will cut this all out and reanastomose it there. It's pains of colicky pain, bloody stools, a lump in their abdomen, they're lethargic, they have diarrhea, fever, and vomiting. And that ileum telescopes inside the ascending colon. And it really is a very painful thing for these infants, and it's a freak out for the parents. It says the blood vessels become trapped in layers, blood flow decreases, edema, strangulation of bowel, and the worst side effect could be a gangrenous colon, so causing sepsis and shock, and that, you know, they could die from it. So a lot of times ER pediatricians will get called in, and pediatric surgeons will get called in, and they'll take them to surgery. If it's a very small portion that can be used, the hydrostatic, they'll do that. But again, not fun for the parents, not fun for anybody involved. A celiac disease, gluten intolerance, atrophy of the small intestine in response to gluten. I don't know if anybody has celiac disease, but there's a lot of things that have gluten in them. So signs and symptoms, slow growth and diarrhea, abdominal distension, there's that muscle wasting and a poor appetite. So you avoid barley, rye, processed oats, wheat. So BROW, barley, rye, oats, and wheat. And when the pandemic hit and all the food was getting off the shelves, all the gluten-free aisles were full of food. So nobody likes to try to eat that stuff. I'm not sure. I mean, barley, rye, processed oats, a lot of us eat a lot of that. And it says the small intestine would look like that, and that's the normal villi. Celiac disease, the damaged villi, you see it all broken up in areas, and this nice normal villi is what is in the intestine lining and helping you process your food. So celiac disease, you make sure that they have the right diet, the kids that are eating, staying away from these. And not only that, if they do have an exacerbation or somehow get that food, you would have to try to treat the symptoms. This is a gross one. We're almost done. I'll give you a quick break. Oh shit, it's already 11:30. Well, we have 1 hour, right? We're till 12:30. Yeah. So the pinworm, we'll do this one. I think that's all it for these slides. Transmission is oral, fecal oral. It persists in indoors up to 3 weeks, contaminating anything they contact, toilets, bed linens, clothing, blanket, all of it. Signs and symptoms is an intense perianal itch. So you see little kids scooting around like little cats and dogs that are itching their bottoms. And that's no lie. Little kids will be itching their bottoms like that on the ground. It's very intense at bedtime. How do you do the test to know that they've got worms? You wait till they fall asleep, you open their little rear and you look in the little opening of the rectum and you'll see little tiny white strings. You can get a piece of tape and look at them and it looks just like that. The good thing is the treatment is one pill. So everybody that lives in the household with a kid that's got pinworms takes one pill. It's called Vermox, and everybody's free of the itchy bottom. It says here, the Vermox is for over 2 years of age. Under 2 years of age, the treatment may be a little different of the Povan, which stains stool and emesis red. All family members must be treated. All linens, bed, toilets, everything needs to be bleached. All linens need to be cleaned. Where do kids usually get this? From playing in sandboxes, where cats pee and poop, where dogs pee and poop. Yeah, not fun, kind of gross. So it's provided Amy mostly at night. They do the paddle test. They'll check kids to see. They'll go in, reach into the rectum, and then they'll do the test in the lab and they'll tell you you do have them. Generally, pediatricians will take a look. They'll discuss with the parents what the symptoms are. And instead of doing all that, they will prescribe that Vermox and tell them to go clean their house. They'll come back in a week and everything's fine and everybody's happy again, instead of going through all of that, because the chances are that that's what it is are a lot higher than having to go through any type of expensive tests to try to figure it out. You don't generally see this in the hospital with kids, but you could. Just don't forget what I tell you is treat every kid like they're infected with everything, and we'll do okay in clinical. All right, we have one more to go. Take a 10 and we'll come back and do the last one for the day. And hopefully I'll see some of you in the Student Nurse Association meeting. It's a very tiny little blip of things to cover for the genitourinary system for the little pediatric patients, and very few, there's not that much to read either, but variances for the genitourinary system. I just like to say GU, it's a lot easier. Infants and young children excrete urine at a higher rate related to the increased BMR, producing more waste. Infant kidneys have decreased function if under stress. Infants can't concentrate urine well until 3 to 6 months of age. In infants, kidneys and bladders are abdominal organs. If kidneys are less protected, because they are less protected because you don't have the unossified ribs, less fat padding, and a larger size. So young children have shorter urethras, which could really cause urinary tract infections in the babies and the smaller children if they're not cleaned properly. So always for little girls, wipe front to back. Little boys, same thing. Front to back, make sure that if an infant or little boy is not circumcised, that you're cleaning around that opening area of the urethra. Nephrons continue to develop after birth. And if you see here, right here in this little toddler, there's that little kidney hanging out. And here, over here in the adolescent, they're getting a little more protection. Minimum urine outputs by age. So infants and toddlers, 2 to 3 mLs kg an hour. Preschoolers, 1 ml to kg an hour. School age and adolescents, 0.5 to 1 ml kg an hour. Tips, bladder capacity in ounces, age +2. That's kind of a good little tip to have. The hemolytic uremic syndrome, or the HUS, is most common cause of an acute renal failure in children. HUS is characterized by the triad of anemia, thrombocytopenia, and acute renal failure. It's associated with GI symptoms, almost always caused by E. coli. So again, almost always caused by, for little girls, it would be not wiping the right way or getting stool in the bladder and causing a urinary tract infection. Treatment is supportive based on symptoms, and serum electrolyte panels may be outside of normal limits. what the treatment would be blood transfusions and or hemodialysis might be necessary. More than 90% of the children recover with good renal function. Some might have a slight renal delay, but it's generally got a good prognosis. It's mainly supportive, no antibiotics, plasma infusions, and plasma exchange. The epidemiology, so it says primary affects children under the age of 5, clinical prodrome of abdominal pain, vomiting, and bloody diarrhea, hemolytic anemia, thrombocytopenia, and an acute injury would be the triad. And then the worst effect would be seizure. Oops, sorry, hold on. Would be seizures and lethargy. The history, emesis, bloody diarrhea, abdominal pain, and urine. The petechiae and bruising or the purpura is one sign that you can usually, pediatricians and healthcare providers will horn in on. Edema, possible congestive heart failure, hepatosplenomegalia or enlarged spleen, altered level of consciousness, seizures. They get hypertensive, fatigue, and abdominal discomfort, and those are the labs that would be abnormal. Strict INO, daily weights, evaluate for any signs of bleeding anywhere. You monitor for fluid overload and edema. And at the same time, you're going to be assessing for dehydration. We check vitals, we do neuro checks, seizure precautions, make sure that the head of the bed is up a slight bit. Antibiotic, diuretic, and antihypertensive meds are given. Rest in a calm environment. You'll find that in a lot of the pediatric conditions when we're taking care of patients in the pediatric setting. A lot of, you'll see, all the interventions and a calm environment. So keeping the kids like calm down, not super spazzy shows on TV. If they have a tablet, they try to only let the kids do something that's not super aggressive and super, just keeping things kind of calm, a dim light, a warm room, that kind of thing, that kind of keeps the atmosphere a little bit less exhilarating. Provide comfort measures, so maybe some pain medication, and they do monitor the labs closely. In taking care of these patients, you do have generally a very good, like it said here before, 90% of the kids recover fine. And if there is a residual effect in that 10%, it's generally a slight malfunction of the kidneys. So they have a slight bit of their clearance isn't that good. The creatinine clearance isn't 100%. So they're kind of watched, generally watched closely as small children. Not very common. You don't see it very often. Wilms tumor is the one thing that you will see quite often. And it's a large encapsulated tumor that develops in the renal parenchyma. You do not palpate the abdomen because you could rupture it and those cells could break free. It originates during fetal life from an undifferentiated embryonic tissue. And they have a very, very good success rate. One of the nursing students' son, she works on 3 Wood. Her son is recovered from a Wilms tumor. He went through the chemo, the surgery, and the radiation. And I think he's like 4 or 5 years out now. No reoccurrence. He goes back and gets checked annually. Peak age is 1 to 3. It happened when he was 3, and now he's an 8-year-old. Prognosis is good if there's no metastases. If there is, it goes to the lungs first. The treatment is surgery. It's an encapsulated tumor, then chemo, and sometimes radiation. He had all 3. He's kind of got a poster. He's got a poster in one of the cottage, I don't know what you call that. Their cottage literature or their little pamphlets. There's a picture of him in there. And there was this tumor. It was encapsulated. They first went in, they removed the tumor and surrounding tissue. They did the chemo. He had the chemo for 3 months. After the chemo was done, he did radiation for 3 months. And then every 6 months he got checked. He was, cancer-free. And it's been 5 years now. He goes annually. And they make a big to-do on Peds for him. They gave him a parade. The last day he was there, we were there as students. So it was really good. It was a really good prognosis. But again, That's our last slide. When you see it, it originates during fetal life from an undifferentiated embryonic tissue. You know, nobody knows where it comes from, but you don't palpate it, and it's kind of one of those tumors that it's hard to detect. It's very hard to detect because it's almost the same size as the other kidney. Sometimes there could be a slight backache. There could be an elevated WBC. There could be a few things off when the kids get their general annual physicals, but it was detected on time for that little guy. It was removed. He did very well with the treatment. He had his surgery, got tons of toys. They did a lot of drives. It was really a good thing. And he talks about it now as an 8-year-old. So it's kind of neat, but those are just another one of the things that you'll see as a pediatric nurse. You'll see, you know, a lot of different conditions that you may not have ever been exposed to. But with that being said, it's always something new. It's always something interesting. You have one patient in peds that you're going to research. So if you get something like that, it's always good to be able to take a look and see what's going on, see what the plans of care are, and what you actually can do. And not just for that actual patient, but remember, for the entire family unit. We are here. You have Mary on Thursday, and then here we're going to do all sorts of fun stuff because we have the whole day. So we're going to knock out everything that we were going to do in our orientation, those 4 hours, we're going to condense them. Now,